1 minute? 2 more minutes. Ready to start, I guess, I hope. Okay, so welcome everyone. Good morning. I'm Olga Wall from Houston Methodist, and I am a program director for this summer meeting. So for those who joined us yesterday, welcome back, and I hope you enjoyed. For those who are just joining us, welcome. To access presentation slides, please make sure you have the meeting app. I want to remind everyone that TNS is on social media. Please stay connected with TNS on Facebook or follow TNS on Twitter, and you will be automatically entered to win $50 Visa gift card. Hashtag tns2021. So please stay connected with us on social media. I want to remind everyone that we have excellent exhibit hall there. Please attend exhibit booth and make sure that you fill out your exhibit passport to enter a prize drawing. And with that, let's start our morning session. Dr. Clark will be the moderator. Welcome, Dr. Clark.
Good morning, everyone. Again, I would request that people consider wearing masks for the presentations, not the speakers, but the audience, in order to protect you and your family and colleagues. Austin has just moved into stage 4, meaning this is the next thing to almost a shutdown because of a surge in coronavirus cases, and we certainly don't want to be responsible for propagating coronavirus. But we do have a wonderful session today, and we also have a in-person audience and a virtual audience, so welcome to the virtual audience. And today we'll be talking a good bit about some incredibly interesting topics, including our first speaker, Erica Green, who I've known for a number of years. Erica spent time with Stan Appel in his lab and training with Stan Appel, and then moved over to Baylor for a period of time, and now is at Methodist Hospital, where she serves as the Sumner Family Chair in Neuromuscular Research. She's also the program director, which a job that I've had in my academic career, and I know how difficult that job is. So God bless you for taking on that responsibility, Erica. And today she's going to talk about neuromuscular emergencies. We would request that you use the chat feature or for the questions using the app. And we'll have some microphones here too, in order for the present audience to ask some questions of Dr. Green. Thank you, Dr. Green.
Good morning. Good morning. For those who don't recognize Erica Green, my training name was Erica Simpson, and I didn't get remarried or divorced, just decided to simplify my life and take my married name. So I get all types of questions, what happened? You know, but everything's good. Everything's good. So thank you, Dr. Clark. We do go way back. I was a resident at Baylor in pediatric neurology with Dr. Clark, and his work in lissencephaly and migrational disorders, well known. So it's a pleasure to be here. Thank you, Dr. Walton, who's my colleague at Houston Methodist, for inviting me. And let's get started. So neuromuscular emergencies, a very needed topic. This is going to be clinically relevant, and it's one of the ones that I teach my residents very early in their training. Because as they begin to be on the inpatient service or even in the outpatient clinical setting, they're coming across patients who may be straightforwardly in a crisis or undergoing an acute deterioration, but they also have to be able to detect those patients who go under the radar and to be able to manage them. So it's going to be case-driven, a lot of which I think you'll know, but for our residents or those who are not neuromuscular specialists, I hope that it's beneficial. So when we talk about neuromuscular disorders, and I'm a little short, so I'm going to have to move over here. When we talk about neuromuscular disorders, we're talking about a group of diseases that affect the peripheral nervous system. So it really is from the lower motor neuron in the spinal cord all the way out to the muscle, the skin, and the target organs. And so when we're identifying and treating these disorders, it is a special concern for hospital providers because often these patients, because of the muscular weakness, which can be acutely deteriorating, chronically slowly deteriorating with acute exacerbations, or even present as a new presentation for the disorder, you have to have an index of suspicion. And I think if you don't remember anything else from this lecture, it's to have an index of suspicion and to err on the side of caution and treatment first. So neuromuscular anatomy, we'll just do a quick review in terms of what functions and modalities are primarily covered. We have the autonomic system, which often some don't think about with the peripheral nervous system. There's a whole subdivision and specialty on autonomic or dysautonomia related to the peripheral nervous system. The sensory organs, of course, from the vessels, vasomotor responses, skin, joints, and muscles that affect balance, a sense of self, your sensory afferents in terms of our, small fiber, painful, stimulating, tingling sensations that can be abnormal, all the way up to disorders of the dorsal root ganglion with a lot of pain and position sense issues. And of course, the motor components of the peripheral nervous system, from the motor neuron to the root, the plexus, the neuromuscular junction, the muscle, and then any other structures that I've just mentioned in organs. So this is the peripheral nervous system. And this is a very rudimentary drawing of that system. I don't think I have a pointer, maybe I do. But you can see, again, from the motor neuron all the way to the muscle. You can see in terms of the loop from the afferent system to the efferent system there. And so I would say the spinal cord, motor neuron down, again, we're talking about the peripheral nervous system. So what are the major disorders that we come across? This is a long list. It's by, definitely not inclusive of everything, but we have our common motor neuron diseases. I co-direct the ALS clinic with Dr. Stanapel, but there are other acquired motor neuron diseases or poliomyelitic disorders, West Nile being the most well-known right now. Poliomyelitis, we don't see it as much, although we're having some cases. Peripheral neuropathies, Guillain-Barré is the classic textbook case, but we also see others. Zika as well, critical illness neuropathy, rarely a porphyria associated. And in the Gulf, we do see some shellfish poisoning with acute paralytic syndromes. Neuromuscular myasthenia, of course, is the textbook disease, Lambert-Eaton, but there are other acquired, iatrogenic, or toxic-related neuromuscular junction disorders, medication-induced neuromuscular junction dysfunction that needs to be considered depending on the case and the context. And of course, we have our muscle inflammatory myopathies being the most that we think about, but even rhabdo and possibly a toxic or necrotic myopathy with an acute deterioration. All of these things, because they affect the function of swallowing, breathing, handling secretions, need to be considered. And so these are some of the presentations, the symptomatology that we see with neuromuscular emergencies related to acute weakness. And what I've done is I've reddened or changed the color for the ones that seem to be common, no matter the level of the peripheral neuropathy or peripheral nervous system anatomy. So dysphagia, neuromuscular junction disease, muscle, of course, but even nerve, depending on what nerves are affected. Okay, such as Guillain-Barré, the Miller-Fisher variant, or the brachiopharyngeal variant, where you get a lot of bulbar involvement. Hypoventilation, of course, because you might be affecting the phrenic nerve, or if it's a muscle issue, the diaphragm, the intercostal muscles, okay? And then for motor neuron, of course, the above. So these are the common presenting symptoms that we see and signs, and they're common to whatever level of the peripheral nervous system may be involved. So we're going to talk about a general approach to these patients. And it's what we've learned, the ABCs. The ABCs. Is this patient stable? Is the breathing compromised? Is failure imminent? Should this patient be in the ICU or IMU? What's the patient's pre-existing code status, which for ALS is very important for us before they present to the ED. And then more specific questions that you can consider, is this a problem of the nervous system? It doesn't have to be. Patients can present similarly until you examine them and get a history. Okay. What's the localization? What disorders localize there? And is this a new onset or is this an acute on chronic exacerbation? What investigations and what specific management is indicated? Some of the key elements, is this a pre-existing disorder? Does this patient come in with ALS or myasthenia gravis? Does this patient come in with a peripheral neuropathy or even a dystrophy? And the thing is that a lot of times when people see a chronic patient, specifically I'll use ALS as the context case, they're already weakened, and non-neurologists or those who aren't familiar with seeing them don't realize that there can be an acute on chronic exacerbation, and they treat them as just a chronic person with a pneumonia or a chronic person with a viral syndrome. And so that applies to not only ALS but other chronic progressing diseases, even slowly progressing diseases such as muscular dystrophies. Is there a pre-existing non-neurologic condition? Is there a malignancy? Is there a thyroid issue? Is there heart failure? Because all of these things can exacerbate or add to the comorbidity of your patient. And what drugs are the patient taking? Any recent illnesses? Where have they been? What do they do? Are there exposures? Are they fishermen? And we have had Botox from canned goods. We see that at least once or twice a year. Okay. So there's a long list of drugs per disease that need to be considered. But we've had patients who've had severe hypokalemia from overdiuresis or thyrotoxicosis or extreme use of inhaled beta agonist, which can have secondary effects, who present with a paralytic syndrome. Okay, so just to let you know that. Hypermagnesemia, magnesium-containing antacids, mostly concerned with neuromuscular junction, specifically myasthenia, but not all the time. Okay. And of course, you have the myotoxic agents. Usually don't occur or cause an acute process, but they could be progressing slowly and then present to you because of some other triggering or tipping over event. And of course, demyelinating neuropathy. And I apologize, we're not going to talk about checkpoint inhibitors, but I think it's very important as patients are now being treated with these phenomenal drugs that we are seeing them present to us with autoimmune disorders. We are seeing them present to us with new onset myasthenia gravis. And the only history we have is that they're on checkpoint inhibitors. So in terms of the physical exam, I always say err on the side of caution. Deal with your ABCs. You don't have to be sure of the diagnosis. You don't have to be aware of the level or the stage of their disease. You may not even know if they're on BiPAP or CPAP or AVAPs at home. but assess your patient, and if there's concern that they're struggling, they're not handling their secretions, you're concerned that they're about to decline, err on the side of caution and be proactive. Because what happens is, depending on the disease and the case, these patients will do this and then do this unexpectedly. So is there slurred speech? Is there dysphagia, excess secretions, weak cough? Are they using accessory muscles? Are they having trouble holding their head? All of these things regionally tell you that this area, the oropharyngeal area, is compromised, or the breathing ventilatory muscles are compromised. And then what's the pattern of their weakness? Do you see rounding of the shoulders? Are they doing this? And we always tell our residents, take the shirt off, look at the patient. Sometimes just looking at the patient with their shirt off will tell you volumes about what's going on. And I have a case at the end where that was very evident, and this patient was totally missed. Okay? This is just for your records when you download the PowerPoint, but this is just a nice table from, I believe, Continuum, and it just kind of talks about the different levels, the category of disease, the key elements, the laboratory and electrodiagnostic findings, and some of the examples. So these are the red flags: shortness of breath, not being able to lay down. So if someone's coming to you, their speech is clear, but they're kind of a little short of breath, they're still saturating well, but they tell you, I can no longer lay down, then you need to be concerned, okay? Inability to count with a single expiratory breath, and we'll talk about that. Very good bedside measure. Are they breaking up their speech? Can't finish talking and completing a sentence. And then, of course, neck flexion, significant. And then, are they stressed? Is there sinus tachycardia? And then the bulbar, is there a nasal speech where it sounds like they have cotton in the back of their throat? The posterior palate is falling down. Very concerning. Think about imminent aspiration at the very least. So these are cases that I've had from early in my career to even as a resident. And you know, many of us have those cases from our training or our career that will stick with us forever. And so these were my cases. So this is a 58-year-old man who was transferred from rehab. I had just started as a new faculty at Methodist. And so I'm all gung-ho, and I'm busy in the clinic, and the nurse calls me and said, "You're a patient." I accepted a transfer, and he arrived from a rehab unit in North Texas, and he had generalized weakness, and they couldn't figure out what he had. They did an EMG nerve conduction. Actually, they just did a nerve conduction and a little bit of neuropathy, and he ended up needing a PEG because of dysphagia, and he was short of breath, and they really just couldn't figure out, so I took him. I'm in the clinic, and the nurse, one of the strongest nurses on the unit, said, "Your patient's here, and his vitals are stable, and he's satting 95%. Okay, thank you. Get the consults, I'll be there. Upon arrival, I walk into the room, and my patient is unresponsive. And a code blue is called, and his PCO2 is 65, his O2 is 85, he's acidotic, probably chronic with an acute exacerbation. Sorry for the small font. He's intubated, gone to the ICU, he has pneumonia. Once he sort of starts to wake up, we're on his exam. He's very weak, extremely weak, areflexic. He has some positive reflexes as well, and diffuse atrophy. So what do you think he had? He showed acute and chronic denervation in arms, legs, back muscles, tongue, diaphragm, consistent with motor neuron disease. He was trached, ventilated, didn't like it, and wanted to be withdrawn in less than 6 months. And so this was a person who had been progressing, had not been diagnosed, was in a rehab unit, transferred to me. I'm in clinic. His saturations were fine, and we'll talk about that. So as you know, ALS and other motor neuron diseases are associated with skeletal muscle weakness, whether it's lower motor neuron or upper motor neuron, and they include the muscles of breathing, so your diaphragm, your rib muscles, your upper airway muscles. And it's the major cause of complication and decreased survival. And hypoventilation, the inability to expire the air adequately, results in progressive CO2 retainment. And often the room air saturation and oxygen will remain normal until late in the disease. So if you're basing how well they're breathing on an oxygen saturation, you're not picking it up, because that will remain normal for a long time. Early symptoms can be subtle and easily overlooked. Shortness of breath with minimal exertion. They're sleepy all the time. They wake up, but they're sleepy all the time. They're irritable. They may feel a little lightheaded if they are able to stand up. Things that suggest that there's chronic accumulating hypercapnia or elevated carbon dioxide, morning headaches, fatigue. And so it can occur, respiratory failure, in a chronic mild to moderate setting, especially if something tips them over, like a pneumonia. So just a quick review in terms of the anatomy of inspiration. Our inspiration is active, and the principal muscle important for that is your diaphragm. Okay? When we're just normal, not exerting, we're not thinking about it, but this is an active muscle. It's purely skeletal or striated muscle. It's fajita meat, as they say. That's what it is. And basically, when we take a deep breath, our diaphragm activates, it goes downward, it creates negative pressure, and air comes in. And then when we exert ourselves, that degree of contraction increases, and our rib cage activates to expand our ribs so that we can even take in more oxygen. Okay? Expiration is more of a passive thing, and this requires more of your abdominal muscles, which push the air out. It's also the muscle very important. Those expiratory muscles are important for clearing and coughing. And so pulmonary function studies require some discussion. I would say that if you suspect or know that you have a neuromuscular patient, that you need to know their breathing status. You must get pulmonary function studies. If they're relatively stable in your clinic, get a baseline. Okay? Depending on how fast or slow their disease progresses, at least get an annual, biannual, right? You really want to monitor them to get a baseline. If they present with an acute decompensation or worsening, you get another one. And so the forced vital capacity is an overall lung strength measure. So it's the maximal volume of forced air exhaled. And it should not drop greater than 15% when we lie down. We'll talk a little bit about a lying down measure versus a sitting up measure, if they can lie down. And in many ALS patients, the FVC decreases greater than 15% when lying down. That's also important to know, because when they're upright, it may be relatively good, but then it'll drop 20% when they lie down. And we often use that to qualify them for BiPAP or AVAPs, the supine vital capacity. The other measure is the maximal inspiratory pressure, and that is the amount of negative pressure we generate when we with a closed nose. And that is an indirect but reliable enough measure of your diaphragm strength. Your diaphragm strength. Remember, that's the active muscle for inspiration. So your mean inspiratory pressure we use typically in the outpatient setting to see how strong your diaphragm is. And we'll use that before we'll use the FVC, if you can get it. This was a study, and forgive me for not putting the reference in, but it was 1994, and if you ask me, I'll tell you later. But in ALS, there was a study that looked at the MIP as an indirect measure of diaphragm strength. And the reason why the MIP in the ambulatory setting is so important, because it reflects the diaphragm, is that the diaphragm is so important. It's important for breathing at rest, if you exert yourself, if you're laying down, and especially if you're asleep. And our sleep medicine specialist here can tell you that when you're in REM sleep, the only muscle that moves is your diaphragm and your eye muscles. Those are the only, otherwise we're in a paralyzed state so that we don't act out our dreams. So sleep is very dangerous, actually. for neuromuscular patients. Being in a supine position can be dangerous because if the diaphragm is already weak, much less their oral patency, when they're in REM sleep, the only muscle moving is this. And if you're laying down or doing this, you have all the abdominal contents pushing up on it. So that diaphragm has to work that much harder to ventilate, much less the collapse of these structures. So just think about the mechanics of that with any neuromuscular patient. I'm going to extend that to the acute setting where your transporters, your nurses assistants will lay your patient down flat. And we've had coded patients that way because the hospital lays them flat when transporting them. So what this shows is that the earliest signs of diaphragm weakness will be reflected often by a measure such as the MIP before the vital capacity drops significantly. And so this was a nocturnal oximetry study overnight. And these are from ALS patients who had an FEC of 84% or better. And so you can see during REM stage sleep that the oxygen saturation dropped profoundly. Okay? And so we do sleep studies on most neuromuscular patients. I do, especially those who I'm most concerned about if I think that AVAPS or BiPAP is indicated. That's actually part of our standard of care. The AN Clinical Practice Guidelines in 1999 only recognized the FEC of 50% or less as criteria for non-invasive ventilation. We now know that the MIP as a measure, or even the sniff, which is a very similar measure done in the inpatient setting, is more sensitive in detecting respiratory compromise earlier than the FEC, or even a supine FEC. So if you're concerned and the FEC is relatively good, they're satting good, even if their vitals are good, get those measures. Get a sniff in the acute setting, get a MIP in the outpatient setting, or ask them to lay your patient down and get an FEC. This is from the guidelines. This is just a sort of an algorithm for ALS and management with breathing. I included it in here with the link to the guidelines just for your review and resource. So the risk of respiratory failure is not the same across the disorders. So this is a table that really highlights the ones that you really can't avoid monitoring. Of course, the muscular dystrophies, specifically the Duchenne muscular dystrophies, ALS, which I've talked about. There are some other sarcoglycanopathies, limb girdles such as 2I, very known for fairly rapid or unexpected respiratory failure. Some myofibrillar myopathies. Frequent respiratory failure, spinal muscular atrophy type 2, which we see, or 3, we don't really see ones in the adult population. Type 1 myotonic dystrophy, huge. I didn't even include that case to you. And they can be chronic and talk to you and severely hypersomnolent and blue fingers. And my patient refused to go to the ED because myotonic dystrophy patients can be very stubborn. And he died in 2 days. Guillain-Barré, MG, FSHD, and occasional we see it with the Becker dystrophinopathy. Charcot-Marie, of course, I very rarely see. Inflammatory myopathies, it says it's occasional. I would say maybe bring that up to frequent depending on the type of inflammatory myopathy. And then the rare or the oculopharyngeal, they're more at risk for pneumonia, CMT, and CIDP. So this is what, if you have an acute case or in the ED, this is what you should ask them to do. I want a vital capacity, I want a MIP by respiratory therapy or a NIF. Ask them to get a MEP. The mean expiratory pressure is actually the opposite of a MIP. It's the expiratory pressure, that they exert, and it's a good indirect measure of the cough strength, of the expiratory muscles. And get a blood gas if you can. because if they're oxygenating well and they're hemodynamically stable, you want to see at least before you admit them how you're going to monitor them, how closely you're going to monitor them if the PCO2 is a little elevated. So just little pearls here. Normal vital capacity is 6 milliliters per kilogram. So in a 70 kilogram person, that's 4 liters. So if you're asked, you can do a bedside measure. Let's say the respiratory therapy can't get there for an hour. You can do a bedside measure. This is what we teach our residents. And you can ask the patient to inspire. Sometimes they can if they're that bad, but if they're that bad, then you should be intervening. You ask them to inspire, and then you have them to start counting. And I'll show you. I'm not embarrassed. 1, 2, 3, 4, 5, 6, 7, 8, 9, and you ask them to go as high a count as they can without taking a deep breath. So at 50, 51, 52, 53. And so usually to count to 10 is 1 liter, 15, 1.5, 20, 2 liters. The normal is usually 40 and 50. My swimmers can get to 60. Be aware of false positives, bulbar issues, inability to make a good seal with the vital capacity and the pulmonary function. And I talk about the supine position, but I put that there because that has happened to our ALS patients. We've now had to train the hospital how to treat our patients. And I'll talk about that at the end, is that you not only have to be the doctor for your patient, you have to be the doctor for the system where your patients go. You have to educate them about your patients. This is a study of how the vital capacity changes with different positions. And you can see in Trendelenburg, it's 14.5, in the lithotomy, it's 18%. And so it drops significantly, and this is for normal. This is not for diseased. So the NIF is a negative inspiratory pressure done at the bedside in the inpatient setting. The MIP is usually done outpatient, and they're instructed to inhale maximally on a closed valve, and they measure the forced pressure of expiration. And so the normal is greater than a negative 80 generated for a male, greater than 70 for a female. And so if it's below 60, then you're getting into the area of respiratory weakness. If it's below 30, this is severe. Again, the MEP is a reflection of the ability to cough or clear secretions, typically 140 or 95 for the male and female respectively, helpful as an indication for cough, as well as a peak flow rate or other measure. And so I just wanted to mention some other bedside pulmonary function studies. I typically do just the single count. I think to have them do in the acute setting, they're really not able to do that, but you can do it in the ambulatory setting. So we talked about the single breath count. We talked about the breath. We'll talk about the breath holding test, how long they can hold their breath. And these are some of the measures, indirect measures of their vital capacity. Being able to blow a match about 6 centimeters from the face with their mouth wide open. And then the cough test, inadequate or ineffective. And usually to have an effective cough, your vital capacity needs to be 3 times your tidal volume. So for ALS as the context case, or for any patient who has these measures that are in the lower than normal range, in the ambulatory setting, I screen my patients with a sleep study. I screen my patients with a sleep study, and you may ask, why are you talking about this for emergencies? Because your patients will do better if in the ambulatory setting, if there is neurogenic hypoventilation, that they are already on a BiPAP or AVAPs, or if there is sleep apnea, that they're on a CPAP. Okay, so when they present to the ED, often their families will bring it. Okay, you've given them some reserve in the ambulatory setting, and a lot of times we can minimize this. So getting a sleep study on neuromuscular cases, especially the ones that are unavoidable and frequent in terms of respiratory failure, I believe is standard of care as a screen. So for the acute setting, and I'm going to go into some cases where this is relevant, elective is always preferred over emergent because of complications. And in the acute setting, how do you know when to intubate? So it's based on those respiratory measures that I've given you, but there is a classic rule that maybe you've heard of, the 20-30-40 rule. And it was actually developed to know when to intubate a Guillain-Barré patient, okay? So the 20-30-40 rule is when the vital capacity is less than 20, the MIP or the NIF, or the MIP is less than 30, and the MEP is less than 40, okay? If there's obviously progressive respiratory acidosis, hypoxia, difficulty with secretions, mucus plugs, somnolence, or just a lot of bulbar dysfunction, a lot of secretions, they sound wet. They sound gurgly, okay? They sound just drowning is what I say. So before we get into a few other cases, there has to be an index of suspicion. The oxygen saturation does not reflect the ventilation. Check these regularly. And the goal is to educate patients. Education of patients is clear. I have to partner with my patients because we're all working in systems where the system doesn't know your case, doesn't know the patient's disease. And so when they go elsewhere outside of where you practice, sometimes they're at risk by the medical system. So educating your patients on what to do, to get a plan, all of those things. And sometimes my patients do a single breath count at home. They do their own single breath count and they'll say, oh, I got down to this and I know I was in trouble when I couldn't go above 30. So this is a 52-year-old man, post-op day 7. This was a VA, a vet, an honorary vet who I had in my continuity clinic at the VA. And he's passed on. He had an iliofemoral bypass with persistent dysphagia and dysarthria post-op, and the surgeons consulted us about a week later. And I walked into the room and he told me to get out. And he had facial diplegia, dysarthria, labial lingual weakness. He was draining and he just wanted to go home. You know, he had horses, he had to get ready for the trail ride and he wanted me out of there. And I basically told him, I said, I'm leaving, but I'll be back. Before I even got back, he went into a code. He went into respiratory failure. Just to let you know, he had been given an antibiotic, a cephalosporin, perioperatively, and prior to admission, he had had some suggestion of neuromuscular disease. We became fast friends, though, after that, I'll tell you. So his vital capacity was 1.1. If you calculate the 60 mil per kilogram, that's a concern already. And the reason why I say that is if, like me, you were taught in your residency that you only get concerned when the vital capacity drops below 1, that's wrong. You must calculate it based on the weight of the patient. That is the best measure of if they're in trouble, and he was already in trouble. Okay? So that what we were taught, if that's what you were taught, put that aside and calculate it. Anyway, he ended up having myasthenia and a thymoma, and he was seropositive, and I kept him in my clinic until I graduated. So just very quick, I don't need to tell you about myasthenia. It's fluctuating weakness, easy fatigability. The majority of patients present with ocular symptoms, but then the vast majority progress by a year, definitely by 2 years, and by 3 years, if they haven't progressed, it's likely just ocular myasthenia. I can answer questions to this, but you guys are very familiar. And there are, it's an autoimmune disease, obviously, and there are antibodies associated with it. The most common is the acetylcholine receptor antibodies. You have your MuSK-specific, which is seen in the minority, but a little bit more aggressive, the MuSK-specific, a little bit more bulbar and pharyngeal, and the respiratory exacerbations can be unpredictable. So just a little aside. Then you have your rare lipoprotein receptor related and your seronegative. We know about the thymus gland. The majority of acetylcholine receptor positive patients have thymic hyperplasia. There is now standard of care to remove the thymus gland in acetylcholine receptor positive patients, at least up to the age of 60. And then the elder or the older population, males typically have a thymoma, such as my patient. And we don't see the thymic pathology in MuSK patients. So this is just a reminder. But it's important to know that in myasthenia gravis, a myasthenia gravis patient is at risk for a crisis, specifically in the first year or two. But I have had patients who have been stable for 10 years who I thought would never get sick, who had a crisis. And so you just keep working and you'll see it all, right? And so it's estimated that 15 to 20% of patients will require invasive mechanical ventilation in their lifetime. We've talked about the signs and symptoms of that, which are the same. This is a disease that is very sensitive to triggers, very sensitive. And that's part of how I educate my patients. So when you're reviewing and evaluating your patients, you want to see, is this patient been seeing a neurologist? What medicines are they on? Are they on plasmapheresis? Are they on steroids? What other medicines were you recently diagnosed with an antibiotic? Okay. Have you recently been sick? Did you get a vaccination? Did you just have surgery? And people underestimate the role of stress, heat, and of course other diseases. The winter time, my myasthenics come into the hospital. And it's not because of the flu or virus, it's because the good stress of holidays. So and so this is a list that you can Google. You can go to Myasthenia Gravis Foundation of America. You can find this list of the drugs that commonly trigger myasthenia gravis crises. There are those that are absolutely contraindicated. Aminoglycosides are absolutely contraindicated. So if you have a patient with eye infection and the doctor wants to give them drops, or they've had cataract surgery, you actually have to tell them, do not give them the one with the tobramycin drops in it. Quinolones have a black box warning. Antimalarials. And then you have those with the relative contraindication. And so, sometimes, and I actually give my patients a card that they laminate and put in their wallet with their name on it and a list of these drugs. So when they're in ER in Timbuktu, they can put the card here and make that healthcare provider take a second look. Sometimes that's all they have. Okay. The cholinergic crisis can still occur. Patients are taking excessive anticholinesterase medications. It can be indistinguishable from myasthenia gravis. So they have an excessive depolarization of the muscle from all the acetylcholine. But in addition to the weakness, the neck flexion weakness, the breathing issues, they also have signs and symptoms of cholinergic, too much acetylcholine modulation. So meiosis, sludge, salivation, lacrimation as well. So again, I keep repeating myself, index of suspicion. So I knew that Mr. B was going to decline. I walked into the room and knew it. And I walked out because he kicked me out. And I asked my upper level to see him. And we were busy, and he did decline. So just have an index of suspicion. ICU monitoring for myasthenia gravis, because it's fluctuating, because it can change. You do want to monitor their MIP or their sniff or their FVC fairly regularly. It can be tiring, so a lot of times I'll put them in the ICU, I'll put them on an AVAPS, and I won't tire them up with the testing. If they're less severe and they're on the floor, you want to test their breathing more frequently. The problem is your respiratory therapy might not have the bandwidth to be testing them that much. So you put them in an IMU or an ICU setting so that they have a greater number of eyes upon them in monitoring. Removing the precipitating event in these patients. Obviously, the issues with being sedentary and sick. And of course, the standard of care is plasmapheresis or IVIG for the acute crisis. And 10% mortality independent of the intervention. And so that's the prognosis. Case 3 is a 31-year-old mother who presented with acute distal paresthesias, ascending leg to arm weakness, and she was admitted to the floor with a presumptive diagnosis of Guillain-Barré. 7 days after the onset, her vital capacity was 30 mils per kilogram. BiPAP was ordered to the bed. She could not use or tolerate. EMG and nerve conduction, spinal fluid were diagnostic by that time, and she was treated with IVIG, complicated with aseptic meningitis. IVIG was switched to plasmapheresis, but she started to develop dysautonomia, and she was transferred to the IMU, and BiPAP was still ordered. She continued to progress with her dysautonomia. She began to have facial diplegia, oropharyngeal weakness, and we asked for one, or it was asked for, it wasn't my case. She had a vital capacity of 20 mils per kilogram, but they were concerned about a poor seal. Maybe it's not that bad. She ended up surting. Code blue was called. She was intubated, transferred to the ICU, retreated, cardiology consulted, plasmapheresis. Her stay was very long. She had all the complications you can think about. This was a young woman with 2 children. And I'm not saying that her care was not good. There are just some things we can learn from this in terms of maybe getting her to the IMU and ICU sooner, maybe electively intubating her sooner. Again, you all know about AIDP. I'm going to go through that. This is the pathology of the nerve. It's an acute demyelinating disease. And so you have the nerve, you have macrophages all around here, just chewing it up. And I'm going to go through that in terms of the prodrome. I assume you all know that. And the treatments, ventilatory support, ICU monitoring. Again, that 1 liter was from an old slide. I caution you to measure it based on your weight. And how we treat is plasmapheresis or IVIG. So this is the disease where that 20-30-40 rule came in or has been published, because the whole point is when to intubate. Because non-invasive ventilation may not be safe for your patient because these patients can decline so quickly, because of the oropharyngeal issues, but I think more importantly because of the dysautonomia, which can really complicate your case. And so the recommendation is if your patient has Guillain-Barré and is progressing by breathing or stress, you might want to electively intubate proactively. And these are the reasons. The dysautonomia actually can worsen the respiratory distress, and emergency intubation should be avoided because it actually adds to complications. And so that's the learning point I wanted to give for this case. Luckily, she actually did get better. And being a young person, she recovered, believe it or not, and 70 to 75% do. Age, obviously, rapid onset, need for ventilatory support, and the prognostic factors for clinical disability are axonal degeneration, other associated infections, and dysautonomia. So I'm about to finish here, and because of time, I can't talk about all cases. And I hope that these examples sort of give you an understanding on how to approach your patients, index of suspicion. But I want to talk about how we have to treat the system that we work in. So this is a 62-year-old person with bulbar ALS, ambulatory, working, driving, and admitted for an elective PEG. Anesthesiologist comes, talks to him, and I'm in the clinic, and my resident calls me, such and such is coding in the endoscopy unit. He was given succinylcholine to induce anesthesia. His potassium went to 8. He went into cardiac arrest and never left the hospital for an elective PEG placement. We have to be aware of the perioperative risks of treating these patients. Because they already have inherent respiratory weakness, muscle paralytics, depolarizing agents can have a number of complications, but with blocking agents or paralytic agents, they can have a prolonged degree of weakness even when the agent is pulled off and not be able to be extubated. Succinylcholine can cause rhabdo, but it can also cause an efflux of potassium from the muscle because of that depolarization of an already weakened, denervated muscle. That's what happened. And so we actually try to avoid emergent surgeries. We have a template letter to give to all doctors and anesthesiologists for our patients about what to do and what not to do, and our nurses know to send it off. And some of the things that we tell the anesthesiologist, the surgeon, is what is allowed. Succinylcholine must be avoided, I would say, even in a CMT, because you never know. Because what happens is, with denervation, or even with muscle disorders, there's an upregulation of the acetylcholine receptor. So you activate that with succinylcholine, and you just get this fluid release of potassium. We prefer regional local anesthesia. We want to avoid opioids, of course, all the MG drugs that we talked about. For certain metabolic disorders, body temperature is very important. Acid-base status is very important. And we actually recommend prolonged post-op monitoring before they extubate or after they extubate. We actually have epic smart phrases for this. So the residents know to dot phrase this for any of those cases for the other teams. This is a 41-year-old man referred for a 20-year history of weakness, pain, dyspnea on exertion with change in ability to run since the mid-20s. He stopped working in construction because of his disability. For the past 2 years, he had been going to ER because of just pain, and he was actually seen as drug-seeking. They gave him IV morphine for pain, and he went into respiratory failure and was intubated. I saw him, we worked him up, and we diagnosed him with Pompei's disease. There are neuromuscular diseases that will present, which is a metabolic disease. It's an acid alpha glucosidase deficiency. We now have enzyme treatment. But this and these other diseases listed here can actually present the first time with the presenting symptom being respiratory failure. So I just wanted to highlight that to you. And I want to show you a quick picture of him. I don't know if you can see that. If someone just would have taken off his shirt. And maybe you can argue ED wouldn't have recognized that, but he had been to doctors for 10 years, and that does not look normal. He has pectus excavatum. He has a protuberant belly, and his EMGs were normal. And then the last one, and I'll finish. This is a 52-year-old entrepreneur with symptomatic bulbar myasthenia that I took care of. It was very refractory. Thymectomy, prednisone exchange, mestinon, azathioprine, functioning, but it would have to drink cold glasses of water to get through one of his speeches at his construction conferences just to get through the talk. He emailed me when I was taking emails from patients, unwisely, at 6:30 in the morning to say, making breakfast for my kids, having a little swallowing difficulty, call me when you get in the office. I get in the office at 8:30, and I call, and it's his wife who picks up screaming because he collapsed at home. He had a very thick neck. They had a hard time intubating him. Long story short, he had a anoxic brain injury and had diffuse myoclonus when they transferred him, and in 2 days we had to withdraw him from care. So that's my case that led me to develop a myasthenia gravis patient education conference, change the way I practice so that there could be a plan, so that emails were no longer, I don't email, and I say go to the ED, because that's my regret case. And maybe it would have happened anyway. But part of helping our patients is to educate them, creating a plan so that they know what to do, and that giving them the information so that they can advocate for themselves when they're not in your system. And I'll stop there with these conclusions. We talked about the airway function. In the absence of a known diagnosis, or even with a diagnosis, maintain an index of suspicion and be proactive. Acute intervention prior to seeing the oxygen saturation drop, get those other measures, and then educating the patient and the system to improve outcome and to prevent these complications. So thank you so very much.
Questions? I cannot see anything on the chat, so do you have questions on the chat at all? I see no questions there. Yes, please, come on, use the microphone.
See, I have had one patient who came with myasthenia gravis kind of rapidly progressing with dysautonomic features, sweating and all that. And he vehemently denied that he took any canned food or botulism crossed my mind, but it's so difficult to diagnose botulism in form of a serum test or something. When do you advocate the use of this antiserum for an antitoxin in those cases, because time runs out so fast?
So that's always the challenge. So the question is, you had a patient who had myasthenia presentation, dysautonomia, when do you suspect, and so that you can initiate the serum and the antitoxin? So that's been the problem for the few cases we've had, sir, is first of all, to get a history. You can maybe see that it's presynaptic electrically, but that's not always able to be done. And then you have to contact the agency to get the serum. So unfortunately, most times we're too late unless the history is clear cut. And maybe the pediatric neurologist, I don't know if you still see the botulinum toxin from in pediatric patients, not from canned foods, but from other things. And if that's an easier diagnosis to make, I don't think so, because in time for the anti-serum. I wish I had an answer for you. I think that the history and it being very clear cut, I opened up this can sitting on the counter for 15 years and there you go. Then, you know, you have some history, but it's hard. And so we end up just supporting them.
Actually, I called the NIH and we got it in the evening. Called in the morning. It's amazingly fast.
Well, you need to, okay. Thank you.
Lucky in that way.
You were very lucky. Thank you so much.
Yeah.
Hi,
thank
Dr.
you.
Achari, how are
Thank
you?
you. So I'm
Dr.
well.
Achari was my fourth-year medical student when you were a resident when I was a student at UT Houston. And I became a neurologist because of Dr. Achari.
Oh, my God. All right. That is fine praise. Thank you so much.
Yeah.
Your talk is wonderful, and I really appreciate you educating the patient, the system, and self. I really have appreciated that. But in this era of patients using so many over-the-counter supplements, where we don't even know what are in these proprietary formulations, what methods do you use to educate your patients about that?
That's a very good point, Dr. Achari. So the question is for our virtual listeners is, in an age where patients are taking all of these supplements, new supplements, and we're not sure what's in them, how do we advise them? And so I don't shame the patient. I tell them, bring it to me. Bring me the bottle. A lot of times they can look it up and get the information, and we go over it together. If I can look at the ingredients, so my ALS patients do this a lot, right? And so you get a long list, and I go through, and if I see something concerning, I tell them. And this is what I tell them. I say, if we don't know what's in it, there's no evidence that this will work. If it's a vitamin I'm familiar with, it likely won't hurt. I said, but if there's anything that potentially can impact your health directly, your money, or your quality of life, then it's not worth it. And if we don't know what's in it, I tell them you're taking a chance and you don't want it to affect you in a negative way, plus your money, because often they're very expensive. And so I just partner with them and I educate them. And most times they appreciate that discussion. And so if I don't know what's in it and I don't know what it is, I say I can't tell you, so I can't guarantee you won't have side effects. But I can tell you likely it won't help tremendously. And if you're paying a cost, then you need to consider if it's worth it. And then they typically make the right decision. I don't know if that helps, or if there's any other thoughts to that. Thank you.
Just regarding botulism, it's very common, and it's probably much more common than we think it is in infancy, and it's a ubiquitous pathogen, so children acquire it just from playing at a playground in Houston, Texas, everywhere. And we've seen very subtle cases with asymmetric facial weakness and things that you wouldn't think typically is infantile botulism. But they actually grow the bacteria. We send it off to the state lab, they have cultures that are positive for Clostridium botulinum, and then we determine which toxin it is, but we give them the antiserum. Can you just make a half-a-minute comment about rhabdomyolysis, given that we're in the middle of heat stroke season? It's going to be nearly 100 degrees here in Austin today.
Right. So for rhabdo, in addition to the airway, the breathing, the circulation, it really is the same. You approach them the same. But there are other things that need to be considered. Obviously, with the hypercemia, and the protein in the urine, you want to be careful for renal failure. So you want to get nephrology. You want to hydrate them aggressively. I actually add an amp of bicarb to my bag, and I alkalinize the urine. I also check the heart, because depending on why they're in rhabdo, there may be an existing cardiomyopathy or cardiac involvement. And all the issues with rhabdo can affect the same muscles. So the muscles of breathing, the diaphragm, at the very least the chest wall. I don't see as much choking, but they are at risk for aspiration. So I think in addition to everything we've talked about, hydration, kidney protection, and evaluate the heart is very important. DVT prevention and monitoring is very important as well. Is that okay? Thank you.
Thank you, Dr. Green. That was outstanding. We have the honor of having Dr. Stuart Factor visit us today from Emory. Do you have a computer to hook up, or? Okay. Well, let me just step aside in case you need to do something here. But Dr. Factor received his DO degree from the New York College of Osteopathic Medicine and neurology training at Albany Center in Albany, New York, and also a movement disorder training program at University of Miami. And we know him currently as a professor of neurology and the Vance Lanier Chair of Neurology at Emory University. And he's written a number of wonderful high-impact peer review articles, but we know him particularly for his movement disorder expertise, his 2 edited textbooks on Parkinson's disease, diagnosis and clinical management, and also his edited book on drug-induced movement disorders. And so that's what he's going to talk to us about today, is drug-induced movement disorders.
Thank you very much for the kind invitation to come here, and it's nice to actually speak to a live audience instead of into the black hole of your computer, which is what we've been doing for the last year and a half. These are my disclosures, none of which are related to today's talk. And these are the topics I'm going to cover, not just neuroleptic-induced movement disorders, but I'm going to try to give you sort of an overview of different groups of drugs that cause various movement disorders. And I think when Olga told me I had a full hour, I kind of got a little overzealous, so I probably have a little too much to show, but she's going to give me a warning so we can stop when we need to stop. So let me just start with this slide. It's a little bit old. It's a number of prescriptions for antipsychotics per year going from 1997 to 2011. I think this is federal numbers from the Agency of Healthcare Research and Quality, and they haven't done a newer one as of yet. I looked within the last year to see. But I think what it shows is that there's an increased use of antipsychotic drugs, that in 2011 there was no indication that that was waning, and part of that related to the notion that second-generation antipsychotics had much less risk, And I think what I'll end up showing you is that they do have less risk, but it's still fairly significant. So this shows that neuroleptics are still relevant today, still very important. We still see a lot of drug-induced movement disorders from them. But I'll also comment that with increasing numbers of new drugs coming out, there are increasing numbers of drugs that cause movement disorders. And we need to really be vigilant of this. We just heard in the last talk, a very nice talk about the effect of drugs on the neuromuscular system, and many of these drugs have effects on the basal ganglia and other areas as well. So we'll start with the most important movement disorder, most important because it's chronic and disabling and very troublesome to patients, and it's tardive syndrome, what was before called tardive dyskinesia. The terminology has changed a bit and is still changing, but I like to use the term tardive syndrome to sort of cover all the movement disorders, the chronic movement disorders caused by neuroleptics. And tardive dyskinesia is the classic syndrome of orofacial dyskinesia, but this DSM-5 definition tells you that it's a movement disorder involving nearly any body part. It's caused by neuroleptics. It's important to remember that because there are some things in the some literature that suggests that other drugs cause tardive dyskinesia. I'm not in that group. I don't think other drugs do that. Other drugs do cause similar movements, which I'll show you. It used to be that you had to have 3 months of exposure, but now you can see the definition is more vague because many of us have seen patients with 1 or 2 exposures who've developed tardive syndromes as well. So this is a partial list of the syndromes, many different types of movement disorders, the classical tardive dyskinesia, which has gone by several other names, as you can see, tardive dystonia. Probably those 2 groups are the most common. They make up the largest bulk, but there are several others, akathisia, tics, myoclonus, and tremor, and I'll show you some of these. There are also sensory syndromes, ocular syndromes, and some patients, many have multiple types of movements, so I've called them tardive complex or mixed syndrome. So let me show you a few of these. This is a classical tardive dyskinesia patient. She actually had this from metoclopramide, but you can see kind of the stereotypic jaw protrusion and movement to the side and tongue protrusion as well. Maybe even a little upper facial movements, fairly classical. And then this is a woman, a young woman. We recently saw actually one of our fellows published her with tardive dystonia.
Close your eyes and let your neck do whatever
from
it does.
Lorazepam. And you can see she has cervical dystonia, and you'll see she has more axial involvement. Her left arm is dystonic as well. She has a little hand posturing also. And you can see the arching back. That's the classic axial dystonia that's seen with antipsychotics. You'll see her walk in a second and see this arching back. The tardive dystonia cases tend to be more resistant to remission. They tend to be more permanent. These are a few tics. This is a sort of a vocal or a coughing tic from neuroleptics.
So I think
He came to see us for DBS, actually.
for us, could surgery have any benefits?
Yeah, particularly for this one.
For this, what appears to be some type of a tardive dyskinesia.
And then this is a gentleman with some motor tics. He has this very complex punching his thigh type movement and some facial and neck movements, mouth movements, all of which he could suppress if he wanted to do that.
Okay. Do you notice any movements in mouth, face, hands, or feet?
So those are what drug-induced tics could look like. Need to think of drugs when you have an adult with new onset of tics. This is a patient, one of the more severe cases. I apologize, the film is tilted. It looks like an episode of Batman from the 60s. But she has balism and dystonia, very severe tardive syndrome. And I actually had another video of a patient I just saw a week ago who I took out because it was such a complex, difficult movement it would take too long to explain in a lecture. But you can see some very severe movement disorders in patients. And this gentleman has the old classical pelvic thrusting type movement, which David Marsden called copulatory dyskinesia, but it's this pelvic movement. And it was originally written, Tony Lang, I believe, wrote a few decades ago that this was most common in patients with metoclopramide, but we see it with antipsychotics as well. And then just a couple of quick stereotypies to show you, so you'll see that both of these patients have orofacial dyskinesia, and then they have these stereotype movements, this woman of her legs. And what we actually see with these patients is that they can change, and it can move, in her case, from one leg to the other, or involve both legs. Now, these people don't have a sensory phenomenon, so it doesn't really fit the definition of akathisia. It's just a stereotype movement that they have that's continuous. And you'll see her change to the other leg, and the character changes. That's pretty typical. And this woman has rocking movements, also stereotyped. Very subtle rocking movements. And stereotypies can be, patients can stop them. They're brought out more with distraction, and they can be quite variable. So those are stereotypies. So I just want to mention, the most prominent scale that we use is the AIM scale. That's been used in all the modern clinical trials, but the AIM scale is very old. It's 1975, I believe, was when it was developed. And it's very limited. You can see here there are 7, this is for the severity scale. There are a few other parts, but there are 7 parts. They don't separate the arms or legs. And most of the scoring, the first 4 items, are for the face, which shows you the emphasis of facial movements in these patients. But each of these are scored from 0 to 4, and you'll see when I talk about treatment that this is the scale that's been used in recent trials for TD. And diagnostic criteria have been based on the AIM scale. All of the AIM scale shouldn't be used to make a diagnosis. It's just a measure of severity, but Schooler and Kane many years ago developed diagnostic criteria, which you can see that involve a duration of duration of exposure, and then a severity score. And later on, Glaser and Morgenstern did something very similar to that, and these are still used for inclusion criteria. So who gets tardive dyskinesia? I think this is a very difficult area, but the literature, reviewing the literature, will show that advancing age and women are of the greatest risk. Some argue that affective disorder patients have a higher risk, including bipolar disorder patients. Those with diabetes have more than 2 times the risk. The same is true with African Americans. And there are lots of questions about dosing that remain unclear. Now, does TD reverse? I was on the plane coming in last night. I was reading a paper from the the 1980s that said you had to be exposed for years for this to occur. It just shows you how we've changed our view of this, and they said 50% of patients actually reverse, but it hasn't been studied very well. These are some of the papers that were in the literature, and you can see that remission occurs anywhere between 1% and 1% in this 1989 paper to 62% Hubert Fernandez study. But in these top 4 studies, most of the patients remained on antipsychotics. So we don't really know if they reversed or if they're being masked. The only study without it is the bottom row. Glazer in 1990 had 36 patients that they removed their antipsychotics, and they found that 20% improved and only 2 remitted. So we did a study which was published a few years ago with our resident, Deepti Zucchi, where we looked at 108 patients. We reviewed many charts of patients and just included those who we had follow-up for over time. And the patients were followed an average of about 2.5 years, and only 13% had complete resolution over that 2.5-year time. 2% of them resolved without treating them, so the rest of them were treated with various drugs for this. So TD is a chronic disease. It does not go away in most cases. It does get better over time. It seems to improve, and we showed that here. If you look at the gold bars are the baseline scoring. You know, we called them mild, moderate, severe, and then the blue line is the 2.5 years later, and you can see that the number with moderate and severe diminished, the number with mild increased, but again, they continued to have involuntary movements. And I think the recent clinical trials have borne this out too, which I'll show you. If we look at the number of prescriptions written, this is from the 2011 data, and we look at the number of people exposed. I conservatively estimated 4.5 million people based on those 2011 data. And incidence and prevalence of the disease, I'll show you a little data on that. There could be up to about 1.2 million people in this country who have tardive syndrome of some kind. And that may be a little bit of an underestimation. It's very common. So this is the most recent epidemiology data. These are really very good papers by Carbone and colleagues from 2017 and 18 looking at prevalence and incidence. And probably the key thing to show is that if you look at overall 41 studies, 11,000 patients, first generation or typical antipsychotics caused tardive syndrome in about 30%, and second generation in 20%. So although that's different, it's still a significant number for the second generation. The same was true when they just looked at studies comparing the 2 sets of drugs. And interestingly, a very small number of studies, and this needs to be confirmed, but only somewhere between 5 and 10% of those only exposed to second generation drugs developed tardive syndrome, but again, it depends on the drug too. And the incidence on the bottom row, you can see is substantially lower with second generation drugs than first generation drugs, but still pretty substantial. Just very quickly, reminder that, as I mentioned, tardive syndromes are caused by drugs that block dopamine receptors, and this results in a persistent hyperdopaminergic state, but we don't really know the mechanism of that persistent state. The old theory is that D2 receptors are hypersensitive, and animal models creating such a scenario don't really fit with what we see clinically in patients. And there are several other hypotheses with synaptic plasticity and changes that may occur. Blanchette and his colleagues in Montreal have suggested the D3 receptor may be involved. And morphologically, it's been shown pathologically that synapses actually change, and they get these synapses called perforated synapses, where they actually, a single synapse becomes the synapses enlarge, and then there's multiple areas of contact between the nerve endings and the postsynaptic neurons. So there are definitely changes caused by drugs. I actually saw a talk yesterday where they were talking about similar things occurring with levodopa as well. I just thought I would mention, this is sort of an old notion, but I think it's still important, that D2 receptor occupancy relates to the risk of developing tardive syndrome, and most first-generation antipsychotics have about 80% occupancy, and those are the ones that cause the worst of the TD, or the most prevalent. And if you look down towards the end with the lowest occupancy, which is quetiapine and clozapine, they seem to have the lowest risk for this. So occupancy may be an important aspect of this. And this just shows very quickly, it says extrapyramidal side effects, but includes TD, which follows the same trend, what the frequency or the risk of developing tardive syndrome is with different drugs. Surprising to see some of the newer drugs, like lorazepam, which I showed you the video of, risperidone, those have a pretty high risk for that, and quetiapine has a low risk. I'm actually surprised that olanzapine has such a low risk, as we see cases from that, and clozapine being the lowest. So for treatment, this is from a paper I put out last year, and I kind of think of treating tardive syndrome in a series of steps. So of course, diagnosis first, and then you either get rid of the drug that's causing it, or you change it to a less potent dopamine blocking agent, and then if that doesn't seem to work, or you can't do that, then we move on to first-tier drugs, which are actually FDA approved. These are the VMAT2 inhibitors, and then a series of other drugs that have varied evidence associated with their use. So I'll just talk about that briefly. First, I'll just mention in recent evidence-based guidelines, it's actually been suggested that there's just not enough data to indicate whether stopping the drug actually will improve the outcome of these patients. And switching drugs, also the level of evidence is very low. And if you consider that tardive syndrome is irreversible, it may be too late if we're stopping the drugs by the time they develop the syndrome. But still, these are reasonable things to attempt to do initially. Then the drugs that are used the most are the VMAT2 inhibitors, the newer ones, valbenazine and deutetrabenazine. Both were approved in, boy, it's hard to believe it's been 4 years already. They still seem like they're new. Tetrabenazine's been around for many decades, but approved in the US in 2008. And VMAT2 is a pan-membrane protein that sits in the membrane of the vesicles, and it's very important in sequestering monoamines into vesicles for re-release. And so you can see from this cartoon down here at the bottom, see if I can get that when dopamine is released, it is taken up by dopamine transporter and replaced by VMAT2 into the synaptic vesicles for reuse. When you block this VMAT2 with these drugs, then what happens is most of the dopamine is metabolized by monoamine oxidase, and that's how you get depletion of the synapse from dopamine. And it's been very well known that tetrabenazine has been useful for this for many years. Joe Jankovic and Baylor has been using it since the 80s, I believe, and the group at Columbia was also doing that. So this is just showing you some of the differences between the drugs. They're all very similar. The two new drugs have a longer half-life, and so that they can be utilized less frequently. Tetrabenazine is a TID drug, deutetrabenazine BID, and valbenazine is once a day. And these are the doses, which I'm sure you're aware of. And these changes that occur eliminate the peaks, and so decreasing side effects associated with tetrabenazine, but were developed to try to maintain the efficacy that tetrabenazine provides. I'll just mention there are no comparators with these, so we don't really know how they compare to each other. And just very quickly, The CONNECT-3 study for valbenazine was a 6-week study. It was one of the first drugs that utilized breakthrough status to get approved by the FDA. And the data demonstrated that this solid line is 80 milligrams, this is 40 milligrams, this is placebo. Substantial improvement in the AIMS scale, AIMS severity scale, as measured by blinded video reviewers. So this drug demonstrated significant usefulness. And then looking at the patients who had a 50% improvement in their AIMS score, you can see there was a dose-related change at weeks 2, 4, and 8 with further improvement with time. For deutetrabenazine, there were several studies as well, but the AIM TD looked at several different doses, 12 milligrams, 24, and 36 milligrams. This was a 12-week instead of a 6-week trial. Used pretty much the same endpoint, the AIMS severity scale. And they demonstrated that the higher doses of 24 and 36 milligrams had a very similar effect to valbenazine. 12 milligrams had some effect as well, and there was a bit of a placebo effect, but the higher doses seemed to be useful. So this is the deutetrabenazine 2-year data. Now the 3-year data is coming out, but it demonstrates continued improvement in the AIMS score over time. And this is the valbenazine 1-year data, which demonstrates continued use. And then there was a washout here at week 48. And what you see is a return of the symptoms to nearly baseline, demonstrating that this is masking the symptoms. It's not a cure for the disorder, and that tardive syndrome remains chronic and doesn't go away. These are the side effects. I don't want to go through them in any detail because you probably already know about this, but somnolence is an issue that we see a lot of. Recently, I've been seeing more cases of Parkinsonism from these drugs. We don't see a lot of depression, but depression is something you need to watch for in these patients. So second-tier drugs, just very quickly, there is evidence for 3 other medications. Amantadine has 3 small trials that demonstrated some benefit, and I've had some success with that, using it in the clinic. Clonazepam had 1 small trial, which was very positive, and we still tend to use that sort of as a later choice. Ginkgo biloba is very interesting. There was a very large Chinese trial, and we've been using it in our clinic, and I have to say I've not really seen any effect from this. I'd love to hear from any of you if you've tried it and if it's been effective. And these are third-tier agents where there's really not enough evidence, but enough evidence for us to think maybe they're useful. Levetiracetam, baclofen was used way back in the 80s, and several trials demonstrated responsiveness, and we still use that in some patients. Propranolol is something we've written about, and I still use quite a lot. Even zolpidem and zonisamide have been utilized also. So these are things to consider if the VMAT2 inhibitors are not doing the trick for you, which is not uncommon actually, and you need to make a choice before they decide to go to surgery. Just very quickly, 1 single trial of botulinum toxin for classical TD, injecting just the the oris muscle around the lips, very small doses, found to be effective. And then, of course, for tardive dystonia, there have been no controlled trials, but it's as effective for tardive dystonia as it is for idiopathic dystonia. And just a very quick comment about DBS. So we've been doing some more DBS lately on some of these patients. This is one of the 2 studies that showed some class 2 evidence for response in 19 patients doing GPI targeting. And the 2 main scales were the extrapyramidal symptom scale and the AIMS scale. And what they demonstrated in a blinded portion of the study at 6 months that there was a significant improvement in the extrapyramidal symptom scale, And then long-term, there was a very significant improvement overall in the AIM scale and in the extrapyramidal symptom scale. So DBS can be very effective in treating this. And Malin DeLong, who worked with us for years, now retired, but always said he didn't understand why we didn't do more of these cases because it works so well for it. Just a few other comments. It works fast in DBS, unlike dystonia, which can take some time. It improves the dystonic movements, but also the orofacial movements. And in a year, about half the patients no longer need any medications to treat their tardive syndrome. These are some other drugs that cause chorea. This is a pretty long list, and I don't want to go into each of them, but I'll show you a couple of videos. But important to keep in mind that there are many drugs that cause chorea. I've seen lithium and anti-epileptics and some of the cardiac drugs do this, and antibiotics as well, cephalosporins in particular. And opiates have been reported to do this also. So important to keep this in mind when you're seeing even patients with orofacial dyskinesia, that it could be other drugs. Joe Friedman wrote this very nice paper about do other drugs cause tardive dyskinesia? And the bottom line of this was if antidepressants were associated with orofacial dyskinesia, they usually had antipsychotic treatment recently, but some of them can cause an orofacial syndrome that is not chronic, and that goes away when you stop the drug and isn't really compatible with the diagnosis of TD. So this is a patient of ours that I saw years ago when I was up in New York, and she has she's on doxepin, and she developed this choreic movement. It was more generalized, but she had a lot of orofacial movements. That can certainly be mistaken for tardive dyskinesia, and when we stopped the drug, it completely went away. So the older drugs, the tricyclics, have more anticholinergic effects, and they have a greater tendency to cause this kind of thing. So this is a commonly used drug in a movement disorder center, and just show you a couple of quick videos. So he has jaw and tongue movements.
And while we were there, a large chunk fell off.
He did not have generalized chorea, just these movements.
Absolutely, global warming. But it's incredible to see those glaciers.
And here's another one. Steve Rich actually gave me this video, a lot of orofacial movements. Certainly you could think of this as being tardive in nature.
It's not necessary. You can.
So any ideas? Really common drug we use. That's levodopa. So levodopa can cause syndromes that look like tardive syndrome. And then this is a really interesting woman who took amlodipine and developed chorea. And amlodipine is a really commonly used drug. We've only seen one case of this. But she looks to have orofacial dyskinesia. And she had terrible hypertension. So we took her off the drug and her symptoms went away, and then her internist put her back on the drug and the symptoms came back. And this happened 2 or 3 times. But she had very prominent orofacial dyskinesia. Amlodipine has been reported to cause Parkinsonism, and there have been some cases published in the Movement Disorder Journal. But this was really an interesting case. So let's go on to drug-induced Parkinsonism. Probably the most common neuroleptic-induced movement disorder that we see. There are probably about 1.5 million people in the country who have drug-induced Parkinsonism, more than Parkinson's disease. And the frequency has been varied in different studies depending on what the dose was, what the drug was, what the age of the patient was, a variety of other issues. But studies looking at schizophrenia, for example, showed up to about a third can develop drug-induced Parkinsonism. With depot drugs, it's much, much higher. And with metoclopramide in non-psychiatric patients, it's about a third as well. So I don't think psychiatric diagnosis makes a difference here. In elderly patients, the frequency is about 50%. Stephen in the Lancet in '84 showed 51%, and a 2012 study showed 46% in people taking haloperidol. In children, the numbers are probably lower, but the literature shows a pretty wide range. And this shows that the second-generation drugs cause less Parkinsonism than the first-generation drugs. There's been about a 60 to 70% decrease in the number of cases with using more second-generation drugs, and you can see the differences in those drugs I have listed, single digit for the second-generation agents and over 20% for first-generation. And usually most cases develop the Parkinsonism in the first 3 months, many of them in the first month. It's subacute in onset, usually. Older women are at greatest risk for developing this, and it's very hard to diagnose at times because people are misdiagnosed as having Parkinson's disease. It was especially difficult to diagnose before we had DAT scans available. And they can look clinically identical to Parkinson's disease. They can be any stage. We've seen a few stage 4s. This is from a paper that I did with Christine Esper back in 2008. They can have tremor predominant disease, or they can have akinetic rigid disease, and they can be bilateral or unilateral. So a lot of people think if they present with unilateral tremor, it's probably PD, but that's not really the case. You can actually see drug-induced Parkinsonism presenting asymmetrically. And the DAT scan is very helpful with this. There have now been several studies, mostly out of Europe, that have looked at the frequency of changes in dopamine transporter binding on DAT SPECT, and finding that nearly half of the patients actually have abnormal DAT SPECTs, suggesting that the drugs are unmasking Parkinson's disease. And it's usually the older patients that have these abnormal scans, so very helpful in making the diagnosis. And as I mentioned, it's subacute in onset, and when you stop the drugs, don't expect the Parkinsonism to be gone in 2 weeks. In our study of 25 patients, took an average of about 10 months before the symptoms completely disappeared. And the treatment of this, there are no controlled trials, but the treatment is stopping the offending agent, and if the symptoms are troublesome, then treating them. I usually use amantadine first. In younger people, I use anticholinergics. We do occasionally use levodopa, but it's controversial whether a drug that blocks dopamine receptors would be benefited from giving a dopaminergic drug, but we've used it and found some people to find it effective. So this is a gentleman with bipolar disorder. He's 72, and he was treated for many years with antipsychotic drugs, aripiprazole, olanzapine, and he developed a tremor unilaterally in the left hand, and then it spread to the right hand. And he's bradykinetic bilaterally. So he was sent to me. You see his tremors and his stoop posture. He was sent to me, thought to have Parkinson's disease. We did a DAT scan on him, which was normal. And I've been following him now for 11 years, and he hasn't changed at all, but he continues to need the antipsychotic drugs to control his bipolar. He actually, on his own, stopped his meds, and he had a relapse and had to be hospitalized, so he remains on his medications. It's really important to remember that many other drugs cause Parkinsonism, and I think not enough attention is paid to this. I mentioned the VMAT2 inhibitors. In our practice, lithium and valproate are important. We see that quite a bit. And amiodarone is a really important drug. You saw that listed as causing neuromuscular problems, but we see a lot of movement disorders with that, immune suppressants, antibiotics, and others. So this is a woman, she's 65, and she had a long history of bipolar disorder, and she was thought to have, she had some cognitive change, she was thought to have Parkinson's disease. You can actually see a lot of lithium-induced movement disorders. She has a tremor here, she's got some asterixis. She had been on lithium for decades, and although she had exposure to neuroleptics, they were at least a year before the onset of these features, which came on fairly quickly. So lithium-induced Parkinsonism in general makes up about 15% of all drug-induced Parkinsonism cases. And a study by Connie Maris in 2016 showed that using lithium, you can see her gait, she'll have freezing, which is a pretty unusual thing for drug-induced, but we have seen it in a few people. Freezing, balance difficulties. But Connie Maris showed that using lithium was a risk for being treated with dopaminergic drugs later. So again, more support for the onset of Parkinsonism with this drug. So then we cut her lithium in half, and this is what she looked like just on half the dose. We ultimately took her off of it to the walker, and her walking was much improved. You do? Yeah. Okay, keep walking up the hall. So she really, significant improvement, and improvement in cognition as well. Lithium is known to cause encephalopathies in patients. So this is a patient with valproate-induced Parkinsonism. About 10% of patients who are treated with Depakote develop Parkinsonism. He has akinetic rigid Parkinsonism. So doesn't have the typical valproate-induced tremor that you can see. I'm sorry, it's a little dark, but he has no arm swing, he has a shuffling gait, and is just very akinetic. They too can get cognitive dysfunction from the drug, and interestingly enough, one of the cases we saw developed levodopa-induced dyskinesia when we treated her initially. And then when all the symptoms went away and we stopped everything, she was back to normal. It does take months for valproate-induced Parkinsonism to go away once you stop the drug. And this is a gentleman with tardive dyskinesia who was treated with deutetrabenazine, and he developed pretty severe Parkinsonism. If you watch his jaw during part of it, you'll see his tardive movements. Great. And this is a difficult patient to treat because we lowered his deutetrabenazine, and his, on the other hand, tardive syndrome got much worse, so he went back up again. And we've now had a few of these patients that we've sent for DBS, so they can come off the drug and get their tardive syndrome treated. Both hands. He's got several medical problems, and we haven't made a decision whether he's appropriate for surgery just yet. But pretty severe Parkinsonism. He also had a normal DAT scan. So amiodarone, I mentioned, this is an 81-year-old with amiodarone treatment. He was taking care of his wife with Alzheimer's disease and fairly quickly started to have problems with falling and other issues. I've seen several of these amiodarone cases. The most common side effect is a tremor, mostly postural tremor. Looks like a central tremor. Some of them just get a resting tremor, Parkinsonian tremor, but he has a gait disorder as well, and he has asterixis. You can see a little of it there. He had asterixis of his legs. We thought that was part of the reason that he was falling, actually, because his legs would abruptly give out. You'll see it here. So see some of those drops. I'm going to fast forward to his walking, and you'll see that he actually developed freezing of gait. And he was just on 200 milligrams a day, which is the standard dose. This was pre-DAT scan, so we just took him off the drug, and he had a complete recovery. There's the freezing in the doorway, very much like what we see in Parkinson's disease. And that was probably one of the reasons he was falling also. So now I'll go on to acute dystonic reactions. These are always hard to find to take videos of, but I have a couple of videos to show you of this. This is one movement disorder that has really decreased in frequency with atypical antipsychotics. As you can see up on the top, it's only about 2%, whereas the average for typical agents is about 20%. 90% occur within hours to days of starting these. And you can see when they get, especially depot forms, they can cycle. And you can see that in the ER where they get the dystonia kind of fades away, comes back. You think, okay, we're out of the woods. Then it comes back again. Mostly occurs in young men. And these are the varied distributions. Almost any distribution of dystonia can be seen. You can see oculogyric crisis, which I'll show you a video of, cervical dystonia, blepharospasm, limb dystonia, almost any kind of dystonia. And there's a prodrome where they feel uncomfortable, restless, anxious before they start getting the dystonia. It's very interesting. So this is a woman we saw years ago. She had several episodes. In the OR, she was cycling. And she got prochlorperazine, and you can see she has cervical dystonia, and you'll see she has some hand dystonia. She had oculogyria, but we didn't catch that on the video. You can see she's got a little dystonia of her left hand there, and she's got some dystonia of her right foot. And then this is a patient that Steve Rich just sent me about a couple of weeks ago of an oculogyric syndrome. So oculogyria is not just the eyes deviating, but it's a behavioral change, and it can be an entire body dystonia. And this is one of the better cases that I've seen of it. So this was a woman treated for a psychotic disorder with olanzapine, became acutely psychotic, was given a dose of haloperidol, and this occurred in the emergency room. So you can see her eyes deviating, the behavior changes, the posturing. So we still see these from time to time. You can have some very serious long-term consequences, joint dislocations, acute respiratory compromise, dysphagia, and certainly could be life-threatening. And the treatment, again, no controlled trials for these, but anticholinergics are the first line, or benzodiazepines can be utilized. And in people on given depot medications, they probably need to be treated for several weeks in order to prevent the cycling from occurring. And these are other drugs that cause acute dystonias, antidepressants, levodopa, stimulants. There have been reports of rivastigmine doing this, VMAT2 inhibitors, and you could see the whole list on the right side, even well-described episodes with cocaine use. So this is another oculogyric crisis. I saw this as a fellow. Dr. Green talked about how cases we see as fellows always stick. And so this gentleman developed this oculogyric, mostly just the eye deviation. And so he was treated with the only other drug I know of that causes oculogyria, which is levodopa. This was a levodopa-induced oculogyric syndrome. Okay, so now we'll go to, how much time do I have left? 10 minutes? Okay, perfect. So we'll talk about akathisia, really interesting It's an aversion to staying still. It's a syndrome of both motor and sensory phenomena that occur in patients. And the sensory component is this inner feeling of discomfort and dysphoria. They become very anxious, and they're often mistaken as having an anxiety disorder instead of having akathisia, and so they're sometimes not treated appropriately because of that. And it's so uncomfortable, patients are often non-compliant with their medications. The movements actually relieve the sensory phenomenon, so they're, I think Joe Jankovic used to call them involuntary movements. These can be suppressed, and they're usually stereotypes like I showed you earlier. They can be pacing, they can be tapping their foot on the floor, they can be rubbing their thighs. There's a whole variety of movements that you can see with these patients. There's an acute form with neuroleptics that occurs shortly after giving the drug, and it's very dose dependent, and it improves when you withdraw the drug. And then there's the tardive form, where it occurs after prolonged use and remains persistent. If you take them off the antipsychotic, instead of getting better, they actually get worse. The phenomenology looks exactly the same. In the literature, there's a thing called pseudoakathisia, which to my mind is just those stereotype movements without the sensory phenomena. And so this is a woman I recently saw with severe akathisia, and she's describing the inner feeling.
It's just constriction.
Constriction inside.
And sometimes it feels like the stomach.
Mm-hmm.
And the inside constrictions are relatively new.
Mm-hmm.
I'd say within the last couple of months.
Mm-hmm. That's an excessive case, but quite severe. Most of them are just sort of sitting and rubbing their hands or rubbing their thighs, but she was quite severe. So about the same number of patients with typical and atypical agents, about a third can get akathisia, as shown in the CATI trial, which was a trial of both groups of drugs. It seems to be more common in psychiatric patients. You can see about 20% in schizophrenia patients, only about 5% in cancer patients. And by drug, you can see that haloperidol, almost 50% of patients can develop it, whereas clozapine and quetiapine are less than 4%. And you can see from the listing how varied it is depending on the drug that is being utilized. The treatment, of course, is to, for acute, is to stop the inciting drug, and then the best drugs to treat this are propranolol. There is a pretty good amount of literature on that, mirtazapine, trazodone. Those have been used quite a lot, and we use them in practice. We find them to be helpful. And then if they have tardive, also using VMAT2 inhibitors may be helpful. The woman I just showed you had tardive, and the VMAT2 inhibitors didn't help her at all. And other drugs cause akathisia too. There are a whole array of drugs, mostly antidepressants, stimulants, VMAT2 inhibitors are the most prominent. Now, neuroleptic malignant syndrome, I'm just going to talk about very quickly. Neuroleptic malignant syndrome is an acute, potentially fatal disorder that occurs very quickly in patients who are treated with antipsychotics. The mortality rate used to be about 30%. More recently, it's about 5% lower with atypical agents. And they mostly get hyperthermia. They get severe muscle rigidity, can be with rhabdomyolysis, and they have autonomic changes and mental status changes, and they can get all kinds of movement disorders, Parkinsonism, dystonia, myoclonus. I'll show you a video of a case. And that the lab values that you look for are CK, which is usually up, white count is up, and their iron levels drop precipitously. And if you looked at a bunch of, there were some studies looking at a number of acute phase reactants, and they all changed during these episodes. These are just some other labs that can be abnormal during the episode. And there are diagnostic criteria. I won't review these now, but the Delphi consensus criteria are the ones that are utilized now most for diagnosis. And it can have long-term implications. 40% of patients end up having severe medical or neurological or orthopedic problems, which can be troublesome, and respiratory compromise is the most common cause of death in these people. Renal failure is another. So this is a gentleman who was admitted to the hospital with hepatic disease, became a little confused in the hospital, was given 2 doses of 1 milligram of haloperidol, and he developed this. He became unresponsive. He developed some myoclonus. His CK was elevated. We didn't check his iron, but his white count went up. He had a resting tremor in his hand. He had some dystonic posturing of his other hand there, you can see, and some resting tremor of his fingers. I think sometimes these are recognized in the hospital. He had trismus. So the treatment of this is with dopaminergic drugs. I actually use levodopa now. I don't use bromocriptine. And that gentleman, we gave him an increasing dose of levodopa. And when he got up to 6 tablets a day of 25/100, his symptoms reversed. And he did well. You can use dantrolene as well for this. I'm just going to skip through this and just mention to you that there are 2 other syndromes that look just like this. Serotonin syndrome, which is caused by multiple serotonergic drugs, and Parkinsonism hyperpyrexia syndrome, which is caused by sudden withdrawal of dopaminergic drugs in Parkinson patients. And they look similar clinically. The serotonin syndrome patients have mostly myoclonus, and they have increased reflexes and clonus as well. So I think I'm going to stop here because we're close to the end, right? And I'll just mention very quickly that there are several papers that you could look at that would be helpful for you. We did a group of us did a paper in Lancet Neurology in 2019 that covered movement disorders. Joe Friedman did a very nice paper on non-neuroleptic psychiatric drugs causing movement disorders. I mentioned my paper on tardive syndrome. Olga actually had a very nice tardive dyskinesia paper as well. What year was that? 2017 or 18? Something like that was very good also, which I've referred to a lot. So thank you very much.
Outstanding talk. Any questions?
Just a brief one. I didn't quite understand why you called that pseudoakathisia. You kind of ran through that.
Yeah, I'm sorry. Because there's no sensory symptoms. So in the psychiatry literature, what we call stereotypies are called pseudoakathisia. So I just kind of mentioned that because it's out there. But it's stereotypic movements, just like akathisia, but without a urge to move or without any sensory phenomenon.
We have a bit of a lore in pediatric neurology that if you remove patients from any psychotics prior to teenage years, they're less at risk. Is there any data to support that?
Yeah, I think there is, the younger people are definitely at lower risk of getting tardive dyskinesia, but they're not without risk for that. If you remove the drugs before they develop it, then you are decreasing their risk for sure. But once they get it, like with adults, it can be permanent. Now, there is a phenomenon called withdrawal dyskinesia. I know Joe has written about this. I haven't really seen this very much, but it's mostly in young people where they get a syndrome, looks very much like tardive syndrome. And when you remove the drug, within a month it goes away. And so that's been called withdrawal emergent dyskinesia. You see that more in younger people. No one really knows if the mechanism is the same or whether that developing that younger would increase your risk of developing tardive syndrome later.
The VMAT2 inhibitors, in your experience, how often do you see the Parkinson's disease or Parkinson's symptoms?
Yeah, so I'll tell you that in the clinical trials, they were under 2%. There was just a poster, I think, at the Academy meeting this year on deutetrabenazine, where they specifically looked at the higher doses, 24 and up, and they found the frequency was about 7%. I would say we probably see it more than most because those are the cases that are sent to us. These people with tardive syndrome and Parkinsonism, and the physicians don't know what to do with them. But I think it's probably more common than the literature says.
Is it particularly more with one particular drug, or is it across the board?
Well, if you look at some of Joe's early work in tetrabenazine, the Parkinsonism was about 20%, I believe, of cases developed drug-induced Parkinsonism. So it was less than neuroleptics, but pretty high. I think with the newer ones, it's probably less, but at least with the higher doses, 7, 10, 15% maybe. But something to watch for.
Thank you, Dr. Factor. We'll take a half an hour break. The exhibit hall is open and will be closing soon, so please visit. Thank you, Dr. Factor, for traveling here.
Thanks very much.
Yeah, I'm going to just go a little bit off script for a second and just want to thank Kai Camaro for pulling off another incredible meeting. And this one, with the challenges of COVID, the first in-person Texas Medical Association affiliated meeting. And then on top of that, what I think is the future of meetings, we'll see. This one is a hybrid meeting, so it has both a virtual, how many people virtually? 50 plus virtually. And then our usual, about 100 here personally. And it's just great to see your faces, and I hope that everybody is safe and staying away from the Delta variant of COVID-19. But Kai is just unbelievable. She is, of all the organizations and people that are affiliated with organizations that I've worked with, Kai Camaro is the benchmark. She is the one. So, thank you. And then Olga Wan has put together an incredible program, and we would like to thank you, Olga, for your work and give you a plaque acknowledging the outstanding job that you've done as program director. So I don't know if we're getting pictures. Somebody's taking pictures. So I don't want to be in the picture. For Olga. Thank you very much.
Thank you. Thank you, Dr. Clark.
All right, and then for those that did their homework in the exhibit hall and got their passport, was that what you call it, a passport? Okay. Kai will pick the winner.
We have two.
Two winners. Now tell me what they're winning.
$200 gift card.
Oh my gosh, $200 gift card, huh? It looks like it's Tammy Della Garzan. Did I get that right? Garza. Della Garza. Wow. And your handwriting is actually very good. It's just, yeah, I mean, for a physician especially, incredible. And here's your card.
Thank you very much.
Yes, did she get her passport too? Wow. Okay. Another one. All right, let's see if I can read this one. Nancy Robinson. She seems surprised. So I know, I never win anything either, but you know, it happens. So, congratulations. All right. So, business taken care of. Let's move on to the rest of our program. I just had the pleasure of meeting Daniel Pastula, who has a very unique background for a neurologist. First of all, he's kind of East Coast, I guess, because you went to Brown undergrad, and then you went a little bit further down the East Coast to Duke for your MD and MHS, which I assume is Masters of Health Science. And then he went all the way to the West Coast and did his neurology residency at UCSF. And then he came back to the East Coast and did a CDC fellowship. And I'd be curious to know a little bit more about this, but it's listed as an affiliate medical epidemiologist. You're listed as a fellow medical epidemiologist of the CDC to the present date. And for the state of Colorado, where he presently is, so now he's in the middle of the country, well, sort of, but anyway. He is the state consulting medical epidemiologist as a neurologist, right? And so he is a faculty member and associate professor of neurology of medicine and of epidemiology at the Anschutz University of Colorado Medical School in Denver, Colorado, actually Aurora, Colorado, but Denver, Colorado. He's got a very interesting background in epidemiology. He's interested in neuroinfectious disease and also in autoimmune disease, and he serves as the fellowship director of neuroinfectious disease and autoimmune disease at the University of Colorado. And today, he's going to talk to us about the history of the COVID pandemic in hindsight. Thank you.
Thank you.
That's forward, and then there's a laser pointer.
Great. Thank you, Dr. Clark. I thank you for inviting me all here. I unfortunately do not have any gift cards to give out. However, Dr. Wallem had invited me to come talk on a kind of neuroinfectious diseases, and I said, well, interestingly, I've gotten roped into the COVID response given my background. I'm also on the Board of Health of the state of Colorado and the governor's epidemic response committee that I had been on for years prior to this. And I thought it would be interesting to talk about walking through this pandemic through my eyes and what happened, what I experienced and kind of how I thought through things. And more importantly, what can we learn from all of this? Because I really hope we learn something from this, considering how so much morbidity, mortality, and disruption for this. Hence my title here. So quick disclaimers, anything I say isn't necessarily the reflections of either the state of Colorado or the CDC. I have no financial conflicts of interest, and I can't possibly cover everything related to COVID-19 here. So first, I want to start with an opening thought. First is, hindsight is 20/20, or in this case, 2020. And my goal with this talk is to convince you that where we are right now makes complete sense if you look at what we've learned since the beginning of this pandemic. That where we are right now is a direct consequence of what happened. And to kind of convince you that maybe perhaps we could have averted this in hopes of learning from this. So first, I want to start off with some basic terminology. So COVID-19, probably around, it's coronavirus disease 2019, because it was first identified in late 2019. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. It was initially named 2019 Novel Coronavirus, but then they had switched it once they figured out the genetics very closely related to SARS-CoV-1, or the virus that causes SARS. An outbreak is a sudden increase of disease above normally expected background levels, typically over a limited geographic area. An epidemic is just an outbreak over a larger area, and a pandemic is an outbreak over many countries or continents. And why is it called coronavirus? Well, corona means crown in actually both Latin and Greek. And going back to this, the idea of a crown with the spikes on it actually goes back to the sun god Helios with the rays coming out of their heads. So kind of crowns with the spikes represents rays coming out of the sun. And so here, when they first looked at all the coronaviruses, they saw these spike proteins coming out of it when they did electron micrographs. And those rays reminded them of a crown, the sun's rays, hence coronavirus. So that's where that name came from. So a little bit on some background virology and zoology first, just to kind of set things up. So SARS-CoV-2, it's a positive sense, single-stranded enveloped RNA virus. This is an electron micrograph of SARS-CoV-2. It is in the family Coronaviridae, and this has different genuses. So you have alpha coronaviruses, which are kind of our older, more common coronaviruses, NL63 and 229E, which you may have seen, like if you order your respiratory viral panel, they're sometimes listed on there. And then you have your beta coronaviruses, which are OC43 and HKU1. They're a bit newer, and then that's where your MERS-CoV, the virus that causes MERS, your SARS-CoV-1, and your SARS-CoV-2 come in. Now, in terms of when these first emerged in humans, we think that NL63 and 2290, your alpha coronaviruses, were probably the more ancient ones, and they probably emerged centuries ago, and these are the best timeline estimates. Your beta coronaviruses, however, jumped to humans much more recently. By recently, OC43 maybe about 100, 120 years ago, HKU1 about 50 years ago, and then you see SARS, if you all remember the early 2000s, about 17, 18 years ago, MERS about 7 to 15 years ago, and then SARS-CoV-2, maybe a little more than 1.5 years now. Interestingly, there are some theories, no proof that it's perhaps when these coronaviruses first emerged, each time, they may have caused an epidemic when it first happened until antibodies in the population built up. Don't know that for a fact, but it's very possible that, you know, the first time one of these emerging coronaviruses goes around, it can cause a epidemic or potentially a pandemic. We just don't have data from back then. If we look at where these coronaviruses are, let's see, don't quite know how. You can see the alpha down here. So you see your alpha coronaviruses, NL63 and 2290 down here, split off earlier than some of your other common beta coronaviruses. And then you can see our more recent beta coronaviruses, MERS, and you can see SARS and SARS-CoV-2 up here. What I think is interesting about this in particular is notice there are a lot of intervening viruses in between, and a lot of them are bat coronaviruses, which suggests that bats may play a role into where these viruses have emerged. So we think that the common coronaviruses, so your 2290, NL63, OC43, and HKU1, probably came from some sort of mammal. It may have come, we know that rodents can sometimes get these. We don't know if they were the origin of it or if bats were the ultimate origin of it. For MERS, we think bats were the origin of it that went through camels. For SARS-CoV-1, or SARS, we think it was a civet with bats being the original origin. And we don't really know where SARS-CoV-2 came from, but we suspect it might be of bat origin. And the question is was there an intervening animal? There are some talks about like pangolins, but we don't really know that for sure. And I think this is a good point to make. Bats are the ultimate viral reservoir. I actually, after going through this pandemic, I have a lot of respect for bats now. First off, they comprise of 25% of all mammalian species. So if you add up like all the species, they have so many species, they're 25% of all mammal species. They are very old, ancient order. They are over 50 million years old. They've been here a lot longer than primates. They are highly mobile. They can fly up to 50 miles a night. They live in massive colonies, hundreds of thousands, and they have a very long lifespan. But the most interesting thing is that because they have such a high metabolism and they have to fly so far and have so much energy expenditure, they can't afford to have a lot of inflammation. So they've evolved this like modified inflammatory response that they keep viruses in check, but they don't clear them. So they serve as a reservoir for lots of different viruses. And we think here that intermediate hosts may play a role in it jumping to humans. Again, civet for SARS, camel for MERS. We're not entirely sure if there was one for SARS-CoV-2. And then a little on the transmission basics here. SARS-CoV-2, respiratory virus, primarily replicates in the respiratory tract, binds to ACE2 receptors. Infectious particles, mostly through coughing and sneezing, but also through shouting and singing, talking, less likely quiet breathing, although that can happen. This is a group, MIT kind of did this modeling of what happens to particles when someone sneezes. And basically, they go a lot farther than you think. And so when someone's close by you and they sneeze and don't cover your mouth, it probably goes a lot farther, and kind of hence the social distancing is probably a good idea, even outside of epidemic. We think it's mostly droplet borne, but also probably short-range airborne. So, one of the things I think we learned from this pandemic is we always thought of, okay, you have droplet precautions and you have airborne precautions. It's either one or the other. So airborne, you think of like measles and TB. So if there's like a little bit in your vent system, it's going to get you on the other side of the building. Versus droplet, oh, I can feel the droplets, I can see the droplets, it's 6 feet, they drop out. Turns out that there's probably a middle ground here, that you have short-range aerosols that hang out a little longer time. And this pandemic actually proved that in very tight quarters where you can build up levels, concentrations of the virus in poor ventilation, that this goes beyond 6 feet. And you can get it from just breathing in air that are particles that are still hanging out in the air. So now I'm going to walk through a timeline of what we think happened, and kind of also playing in some of my experience in Colorado. So first, if you look at all of the current strains that are out there, and you do modeling about different viral mutation rates, that we think the current strain, or the most recent common ancestor to all the current strains out there, probably emerged from a single strain somewhere between October 6th and December 9th. They have a point estimate of November 24th, but I probably think it's more of on the October-November range than others. It's possible there could have been other human cases of SARS-CoV-2 prior to this, but they would have died out and not kept propagating. So really, all the strains now basically can be pinpointed somewhere, probably I'd say November or October 2019. So this is Wuhan, China. Wuhan is on the banks of the Yangtze River. It is 11 million people, bigger than Austin, bigger than Dallas, and apparently bigger than Houston, which is really apparently impressive when not being from Texas, I hear Houston's a little big. So this is a very large city. So imagine this setting up in a place like Houston, or actually even bigger than Houston. And this is the Huanan seafood wholesale market in Wuhan. So Huanan just means South China, so this is in Southeast China. And they don't just sell seafood, they actually also sell, as you can see here, lots of meats as well as live animals. So you have a lot of different people kind of going through. You have a lot of, you have seafood, you have meats, you have wild animals, domestic animals, people all in one place. Now what's interesting is the first case that we know in the literature appeared to develop symptoms on December 1st. There was a report of one in the South China Post that may have developed symptoms around Wuhan November 17th, but I can't find any lab results to confirm that. So the first one we actually are fairly convinced we know had onset on December 1st, and that was an elderly, homebound person with no visits to the seafood market, and only their family was visiting them, and the family was asymptomatic, which means they did not get it from the market. Additionally, December 10th through 27th, there were 36 additional cases, and they kind of had a fever, dry cough, this viral pneumonia. And they were admitted to local hospitals between mid to late December. And this is the epidemic curve for that. In orange are the people that had been to the market, and in blue are the people that had not been to the market. So something's going on with this market, but this market isn't necessarily the cause of all of these cases directly, perhaps indirectly, but there's some part of the story we don't fully understand. Could it have been circulating in a limited amount in Wuhan beforehand and then got into the market and then really exploded? Could it have originated at the market and then gone through some people before it got to others? I don't think we know. What's interesting is because this area had suffered from SARS about the decade earlier, that they had some consensus RT-PCRs that could pick up SARS-related viruses. And so when they first got hits, it was reported as SARS. So Dr. Li Wenliang was an ophthalmologist at Wuhan Hospital, and basically he had a WeChat group with all of his medical colleagues that were there. And basically this is a picture of his text coming from the BJ News in China, and he basically said, hey, there are 7 confirmed cases of, he called SARS at Huanan Seafood Market, because he saw reports saying, positive for SARS-like coronavirus, that they're subtyping it. Interestingly, the local police actually took him in and basically said, you're saying untrue statements, and made him sign something saying he's publishing untrue statements for this. So he was trying to warn people here. The next day, the Wuhan Health Department issued this alert. I cannot read Mandarin, but Google Translate is fantastic. And this is essentially what this says, is that you have multiple cases of pneumonia linked to the Huanan Seafood Market. You have 27 cases, fever, shortness of breath, bilateral lung infiltrates. Cases appear to be viral pneumonia. And then they give advice, which says, prevent indoor air circulation, or as loosely translated, is like avoid people all inside with poor air circulation, avoid public places where people are going out and crowding, and wear masks when going out. That came from the Wuhan Health Department on December 31st, 2019. It sounds very familiar to the advice we give today. So then going into January. January 1st, they close down that seafood market, and they start sampling a lot of the, like the cages and the counters, a lot of high touch surfaces, and a lot of samples throughout that seafood market test positive for that, the 2019 novel coronavirus. And then a lot of residents of Wuhan, remembering what happened with SARS, basically are like, we're seeing another SARS, and go out and buy masks en masse and then start staying home. The World Health Organization on January 4th tweeted this out, that basically said, we've got a little cluster of pneumonia cases of unknown etiology, and investigations are underway. And then the WHO officially issued the report of pneumonia of unknown cause. If you ever sign up for any of these like public health listservs, and you ever see something like mystery illness of unknown cause in some place, sometimes that turns out not to be an issue, and sometimes it turns out to be this. So you always get a little nervous when you see those things come around. CDC actually has a version of that. It's called the MMWR, if you've ever heard of them. And it's free to sign up if you ever want to. The next day, the New York Times posted this headline that China grapples with a mystery pneumonia-like illness, and that Beijing is racing to identify these. And you can see already that people are starting to wear masks on January 6th, and you have people getting stopped in transit places. The same day, the CDC issued a travel alert saying that there's a cluster of cases in Wuhan, China. We don't know the cause of it, that it's centered around this market. And it basically says anyone who traveled to Wuhan should avoid living or dead animals, animal markets, and contact with sick people. Generally good advice, whether you're pandemic or not. And that the situation is evolving. So this is already, we're January 6, 2020. So this is way before our lives got upended. January 7th, China isolates the novel coronavirus from patient samples. January 9th, the first death occurred in Wuhan. January 10th through 12th, China sequences the viral genome and then figures out it's a new coronavirus closely related to SARS-CoV-1. Thailand has their first case from Wuhan on January 13th. Japan has their first case in Wuhan on January 15th. And this map shows the different provinces in China, and you can see by the end of January, it is in every single Chinese province, confirmed. So you can see how rapidly this expanded just in January, before we really knew we were in trouble. So January 21st, this headline comes across, first US case of potentially deadly China coronavirus in Washington State. That was a traveler from Wuhan that then went to just outside Seattle who was positive for this, at which point I had kind of seen those little alerts come across my listserv, but after I saw this, I'm like, uh-oh, this is bad. So my friend who's the state epidemiologist in Colorado, I sent her this email that said, literally, I said, "Eek, have you seen this?" And this is on January 21st, 2020. January 22nd, China closes down Wuhan to people coming in and out. As you can see from the previous slides, this was already throughout China by then. So it's a little bit about closing the barn after the horse has already left. So we were already in trouble by then. By the end of January 2020, we think that, looking at modeling, that it already had left China. It was already in Oceania, it was already in North America, it was already in Europe, a little bit in Africa and South America. By the end of January 2020, we think that virus has already circulated, from the conveniences of air travel. Things can travel fairly quickly. So in February 4th, CDC was trying to roll out test kits, but unfortunately the first batch of test kits were faulty. So there was this period, I don't know if you remember, in February that we couldn't test for it very reliably. February 6th, a healthy adult in California, no travel history, died, and then retrospectively actually died of SARS-CoV-2, which means, and they had been sick with a flu-like illness since late January, which means it was circulating in California since late January 2020. Unfortunately, February 7th, Dr. Li Weiang, who was the ophthalmologist who worked at the Wuhan hospital and had warned people, he actually caught a very severe case of SARS-CoV-2. I don't think they fully understand the different ways of transmission, but unfortunately died. And this is one of his group of mourners kind of lauding him as a hero for trying to warn people. And on February 11th, the virus was officially named SARS-CoV-2 and then COVID-19 from that. So later in February, February 21st, the Dow Jones starts declining. And it's interestingly how this all kind of interplays. And that was largely driven, we think, by Apple and having problems with production in China because China was shutting down. And so you have the Dow Jones starting to decline. Then you have cases surging in Italy and Iran. And then during that time, this is a graph of the Dow Jones. The Dow Jones is starting to, and the S&P 500 and all the markets are starting to tank. And then on February 25th, retired Captain Nancy Messonnier, who headed the center's the respiratory center, basically said, we are asking the American public to prepare for the expectation that this might be bad. Disruption to everyday life might be severe. And that, I don't know if you remember, got a lot of press at the time. And then the very next day, President Trump at the time held an emergency news conference and created the COVID task force, putting Vice President Pence in charge. By February 2020, in terms of looking at the modeling, it is on every single continent except Antarctica. And there's probably little data to tell if that's actually true or not. If that could have gotten there from any of the researchers. I don't know. Okay, so now we're in March. And this is, I think, when things really start heating up, or at least we realize they're heating up. As you can see, they were already heating up in January and February. So first, March 1st through 10th, there's a rapid expansion of COVID-19 cases all throughout the United States. And by March 17th, all 50 states have cases. On March 5th, just to go back a little bit, Colorado reports their first 2 cases. By the 11th, we have 33 cases, most of them in ski country from people coming to visit, but also there was an outbreak in a bridge club in Colorado Springs. And at which point we're like, okay, you have ski resorts and you have a bridge club, this is really bad. And so the state of Colorado actually sent a group of us up, they asked me to join them to basically go and figure out what was going on and try to mitigate the outbreak as much as possible. So this is me up in the ski resorts where we didn't quite know the transmission, so I'm wearing a half mask respirator. To investigate. This graph shows in Colorado the number of new cases from throughout March, and you can see we have exponential growth. And we talked about, what, 2 cases March 5th? Look at by March 23rd, we have, what, 1,100 new cases? This is exponential growth right here. So March 14th, after kind of giving our report, we were having so many problems at the ski resorts because the hospitals up there are used to kind of small traumas, and they were getting an influx of people with respiratory issues. And for those of you who've been to the Colorado mountains, you actually have to go, if you want to come down to plains level, you actually have to go up to come down over the passes. So you had these tenuous people, and it was not a good situation. So the governor's ordered all the ski resorts closed in 14. And they said anyone who was up in the ski resorts, including the first responders, you're quarantined. So I was quarantined at my house for 14 days. Then we said, hey, St. Patrick's Day is coming up. Perhaps, given this might not be a good idea. So the Colorado ordered all restaurants, bars, gyms, theaters, and casinos closed on March 16th before St. Patrick's Day. The 18th, Colorado closed the schools. On March 19th, all elective surgeries throughout the state were canceled. All the other Colorado businesses were ordered closed. And then the 25th, the governor ordered stay at home, basically saying, you're mandated not to leave your house unless emergency, like for groceries or prescriptions, but you are mandated. Now, whether they can fully enforce that, it's another thing. So this is actually, came across like 7 a.m. on a Saturday morning. One of the, the loud phone emergency activation systems, this went over. So this was the one that was to my phone. And you can see even the city and county. So in our state, the city and counties can also issue their own thing. So got an emergency alert, went to go to the grocery store. I don't know if it was as bad here as it was there, but this is the toilet paper and paper towel aisle at Target, and this is a picture of mine. Now, while this was going on in Colorado, you remember New York was starting to get really hit with a lot of a big spike. So they were running out of PPE. So if you remember, there was in the news, some nurses had to resort to using plastic bags just to, that's not ideal, but we're just trying to figure out. And this was also during the time we didn't fully know the ways this was transmitted. Like we think it was droplet, but we didn't have a good handle of this. Their hospitals were overrun so quickly, so fast, that they actually had to set up temporary morgues. So those trucks are refrigerated morgue trucks outside the hospitals because they could not have they didn't have the capacity to deal with what was coming. And then President Trump had sent the UCNS Comfort, that's that floating hospital ship, to help with some of the less acute cases. These are 2 graphs out of New York City during this time. You can see the top graph shows you the number of daily cases of COVID-19 in the city, and you can see it went from 0 and spiked to 1,800 cases a day. These are new cases. These aren't cumulative. These are new cases, and you can see it's a very rapid spike in a very short period of time. Very much overwhelmed New York City system. And then the lower graph shows you the weekly number of deaths in New York City of any cause. And you can see normally there's about 1,000. And you can see there's these very rapid spike to 8,000 very, very quickly. So in April 2020, you remember, New York City is this epicenter of all the total US cases, and their hospital system was absolutely overwhelmed. And I think a lot of other states realized we cannot let what happened in New York City happen here. That we might have the number of cases, but we need to slow it down so our hospital systems are not overwhelmed and we don't run out of ventilators. So in 2020, Colorado, we had just issued all the shutdown orders. We were trying to figure out how to take care of these patients. This is me in the neuro ICU. I serve also as a neurohospitalist part-time on there. So this is me seeing a COVID patient. And a lot of this time around the country, particularly around Colorado, I don't know if they did it here, but a lot of the hospital and healthcare workers were really, really, really stressed during this time. And as a show of support, I don't know if it made it down here, but in Colorado, I don't know how it started, but basically at 8 p.m. every night, everyone would howl. And just like all throughout Colorado, wherever you were, at 8 p.m., it was like clockwork for months. They would just howl, and the idea was that to support not only our healthcare workers and our doctors, nurses, ancillary support, but then all our other frontline workers, our grocery store workers, our truck drivers. And I actually have a video of this, Denver one night. Hopefully you can get the audio. Would you mind playing? Oh. No, it's not working. There you go. I actually like the dogs actually joining in too. But like, this was every night at 8 p.m. for months. You would just hear this all throughout Denver and Colorado. And I don't know if it spread here, but a lot of other cities I had heard this had gone on. So May 2020. So it turns out that Colorado's stay-at-home order worked. So this is the number of hours spent at home, because it turns out that every time you have a cell phone, that all the people collect data and then they combine it into metadata that's anonymized, but they can generally calculate out on average where people are. And you can see we dropped the number of hours that we were away from home. And interestingly, that actually started before the mandates went in effect. They really accelerated, but people were starting to stay home already. So you can see we very quickly got people to stay at home. And then our reproductive number, so that is on average, a sick person infects how many people? We drove down from 5 to below 1. So then our cases kind of initially spiked in April and then dropped. And then Colorado shifted after this drop to this safer, what we called safer at home. Basically, it's like you should try to stay at home as much as possible. You're not ordered to, but you really should in this case, and kind of gave guidelines around this. And then this was similarly happening around the country. So in May and June, some states began, quote, reopening. And so there's this article from NBC that basically is a Reopening America. And it was actually getting a lot of flack because they're like, here's a Florida beach where people are crowded. I will give them credit though, they're outside and they're socially distanced. So, you know, it's probably not the worst thing. It's not inside in a very crowded bar. I think what we worry about here is at the choke points, right? When you're inside at bars, at restaurants, and you're crowded in there. That's where that can get dangerous. But generally, you know, and I think, you know, some states would like close down the park systems and like the trails, which never really made sense to me because it's like you want to encourage people to be outside. And there might be some risk on the trails, but it's a lot less than being inside. But then this is stuff we learned, we didn't realize. So then July through December, this map shows all the hotspots in July 2020. Gray just means there's not enough data. So just imagine gray is the area around, you know, has the same color as the area around it. And in fact, it started surging in the southern United States when they were reopening. In fact, it had gotten so bad, your all governor had ordered a mandate to wear masks on July 3rd, which I think, you know, for Texas, that's impressive. You know, government mandates in Texas, I think Colorado, we're a little bit more, we can get away with mandates a little bit easier. And you can see these are the states with mask mandates being issued because we had increasing evidence that masks not only provided source control, but there was increasing evidence that we didn't realize that, yeah, they're not as good as N95s, but you know, they're 50, 70% effective if you have a multi-layer mask about you getting infected yourself. And we're like, hey, that's better than nothing. We didn't realize that before the pandemic, or many of us didn't realize that. And then basically our governor basically got on a news conference and basically said, I'm going to be blunt, wear a damn mask. So you had the cases that were starting in southern United States. Now they have shifted up in September, October to the northern United States and the Midwest. And in fact, it had gotten so bad in the Dakotas that they were offering nurses and doctors like 4 times their salaries temporarily because their healthcare system was collapsing. And they even let people who were positive, like North Dakota issued a advisory letting nurses who had tested positive but were asymptomatic take care of patients, like within the 10-day window, because they had no healthcare staff. And by the time this had ended, about 1 in 500 North Dakotans had died of COVID. They had a lot of cases and they have a very low population. October 2020, actually just prior to this, there were a few events at the White House, if you remember. Won't go into those, but that basically started an outbreak throughout the White House that spread to a lot of White House aides, a couple senators, and then President Trump and his family. And it turns out that looking, back on this from publicly available data, that President Trump was actually a lot sicker than was let on. And they were actually very worried that his oxygen levels were dropping, and they were worried they might need to intubate him. So this was really a much bigger deal, I think, than the media at the time had made it out. You may have heard we had an election in 2020. And so this was all playing, so you had outbreaks everywhere. And so a lot of states decided to say, hey, maybe it's not a good idea to have people in very long lines and crowded areas during an outbreak, and started changing the rules. So fortunately in Colorado, we actually have an all mail ballot, M-A-I-L. And that's been going on forever. So essentially you register, you get a ballot about 3 weeks before the election. You have to sign it. They know it's you. They check the signature when you put it in. You can drop it off anywhere. Like that has like the drop boxes that are drop boxes throughout, and it just needs to be in the drop box by like 7 p.m. of election day. And didn't get anywhere near anyone with voting in the 2020 election for myself. Other states have different rules and challenges. So a lot of states actually made no excuse mail balloting, so those are in the light green. Some states allowed COVID fears as an accepted excuse, but there were 5 states, Texas, Louisiana, Mississippi, Tennessee, and Indiana, that basically said you have to, nope, fear of COVID is not a good enough excuse. You have to come vote in person. And at this time, cases were everywhere. So again, the gray just means there's not enough data, but you can just imagine that's all filled with red. So it's everywhere, except maybe the far northeast and northwest corners. Unfortunately, in December 2020, the Pfizer vaccine was authorized. So you can see here that the data was so good that, I don't know, there's a little nerdy science comic strip called XKCD. And basically they made a comic about this that basically says, for all your researchers out here, here's a little statistics tip. Always try to get data that's good enough that you don't actually need to do statistics on it. And you can see like those curves are amazing from this. And this is me getting my first shot on December 17th. They started with our healthcare workers, and FDA, I think, authorized it on the 14th. It was in my arm on the 17th. So yeah, I was a little nervous because this is, new, but the data looked really good and COVID looked really scary. And then shortly thereafter, Moderna had a very similar efficacy profile. So that was 2020, and that was kind of walking through in hindsight. So where are we now? I'm going to kind of give you a hodgepodge of where are we now, and then I'll talk a little bit about what we can learn from this. So first, the J&J vaccines. This got approved in February 2021. So this is a single dose modified adenovirus vector DNA vaccine. Shortly after this was done, there were case reports or several cases of what they call thrombosis with thrombocytopenia syndrome. And what they were seeing is rare clots. I think the thing that got most attention were cerebral venous sinus thrombosis. particularly in younger women, less than 50, but there were other weird clots like in the GI arteries and some other places. And they saw similar things with the AstraZeneca vaccine. And it looked a lot like heparin-induced thrombocytopenia syndrome. And what they think, we're not quite sure what's triggering this, but with heparin-induced thrombocytopenia syndrome, heparin and PF4 can complex and then cause an antibody production that triggers the platelets. And we're not sure if it's the DNA or something about the adenovirus vector that's complexing with the PF4 in these cases. We're not sure. And I think they're still ongoing. But it's still very rare, much more rare than COVID, and much more rare than COVID hospitalization. But in women younger than 50, should consider one of the mRNA vaccines, particularly if they're available. The treatment for this is IVIG, and the big thing is non-heparin anticoagulation. Make sure if you see this, get your hematology colleagues on board. On April 2021, the FDA paused the vaccine basically to get the alert out to doctors that this is a thing and what to do, and then restarted it. And then very recently, there have been case reports of Guillain-Barré syndrome with this, but again, appears very rare, much rarer than COVID, much rarer than COVID hospitalizations, particularly in men over 50. But ACIP just met and basically said, this is a thing, watch out for it. Maybe if you have a person with a history of Guillain-Barré syndrome, maybe you pick one of the mRNA vaccines. We don't know that for sure, but just be aware of this. But it still helps protect against COVID. Various acute neurologic presentations have been described, and you probably have all seen these. A lot of these, actually, there are very few cases of the virus getting into the CNS. There are cases of that, but it's fairly rare. Most of what we're seeing is spillover from just how sick these people are from systemic inflammation, multi-organ failure, coagulopathy. There is some cases of CNS invasion. They're rare, probably in more immunocompromised people, but they can happen in immunocompetent people. You can get some peripheral nervous system involvement. Initially, we saw some muscle injury with these, and I'll get to the anosmia in a second. And then you can see the post-infectious. So COVID itself can cause Guillain-Barré syndrome, probably at a higher rate than the J&J vaccine, for instance. You also see ADEM, and then we have seen a couple cases of this acute necrotizing encephalitis or encephalopathy, which you can sometimes see with influenza and some other things, which is basically this these pretty bad edema in the basal ganglia. In terms of what's going on with the anosmia, it's fairly specific to COVID versus other respiratory infections. It's not pathognomonic for COVID, but I think it's very specific to it. And it's not simply from mucosal congestion, because once the congestion goes away, people still have anosmia. And then what's interesting is, ACE2 receptors aren't really in the brain that much, and they're also not really on the olfactory neurons or the bulb. But what they're realizing is they are present on all those supporting cells that help those olfactory neurons. So I feel like always our supporting cells kind of get, short shrift to things. But it turns out that the sustentacular cells and the horizontal basal stem cells that really support those olfactory neurons, they're chock full of ACE2 receptors. And we think that's probably what are getting taken out from this. And there's some evidence, at least preliminary evidence, that smell therapy, so kind of what you think of as like physical therapy, occupational therapy, like smell therapy, and some of the ENT journals are like, yeah, we sent someone out to like Bath and Body Works and got like a pine scent candle, and then they're like, just try a couple times a day. And that may speed the regeneration. I know there's some people that this is going on for a while, and we just hope that if it is the epithelial support cells, that they'll eventually come around, maybe not to full, recovery, but hopefully some. In terms of your post-COVID conditions, that's the official name from CDC. Now this is called long haul symptoms. It's a thing. I mean, we hear about this from all of our patients. It's defined as heterogeneous symptoms persisting greater than 4 weeks after infection. It's unlikely from persistent infection. So most people have cleared the virus in this. And it's probably a sequelae of viral damage, inflammatory damage, just from how inflammatory this was, and multi-organ failure at the time. The prevalence just varies widely in literature, and this is where it's very hard to figure out what's going on. It's from 5 to 8%, but something seems to be there. And common things are continued shortness of breath, continued lightheadedness, fatigue, cognitive brain fog. It seems very similar to chronic fatigue syndrome, which you see sometimes after viral infections. I think a couple of points is, one, there's no test to reliably distinguish that your post-COVID conditions are caused by post-COVID versus another cause. I heard an anecdote about someone was having persistent lightheadedness in someone who had COVID, and they were kind of chalking up to COVID, but it turns out they were hypertensive, had gotten anosmia, started losing weight, and it turns out that they didn't need as much blood pressure medication as they did because they lost weight. And they just needed their blood pressure medication cut. So the big thing here is keep an open mind when you see these patients, that how much of this is from post-COVID or how this might be just indirect. Just keep a very broad mind. CDC recommends avoiding excessive diagnostic tests in the first 12 weeks because a lot of these cases do improve unless urgent or, aside from the basic ones. And that they do recommend that the PCP really lead this plan because they're usually pulling in a lot of specialists and there's usually multidisciplinary care. And then the treatment for this is basically multidisciplinary, so get your therapists, if they're really causing a lot of anxiety, get your psychotherapists involved, and symptomatically treat. And hopefully with time, these will recover, and hopefully we'll know more with time with this. Where are we now? So this is the epidemic curve across the United States. So these are new cases per day with the 7-day average, and you can see we had the initial wave, that we stopped with all the stay-at-home orders, and then we had the second wave around summer, around the holidays and fall, this little blip, and you can just see last couple of weeks, we're going back up again. And right now, as of maybe last week, we have 34 million reported confirmed COVID-19 cases in the United States. That's over 10% of the population. That's reported confirmed. You can double, triple, 10 times that, or maybe not 10 times that number, but 5 times that. We don't know how many people have actually gotten COVID. And there have been over 600,000 deaths, either attributed or partially attributed to COVID so far. In terms of vaccinations, this is a map of vaccination percent of those older than 12 by county. You can see a couple states we don't have data, but you can see there are some parts of the country that have much higher vaccine acceptance. So the Northeast is really good. The upper Midwest is actually pretty good. Northwest, you can see along the Front Range here in Colorado, certain parts of the country, but then you can see, sorry, this is a little bit on an angle. You can see that there is a wide swath of country here from like Missouri, Arkansas, Louisiana, some of Texas, out into the Southeast and northern Florida that has lower vaccine rates compared to others. You also see that kind of in parts like Wyoming and the parts of the Western Dakotas, but there are very few people that live out here, and they're much more spread apart. But you can see there are areas that have higher vaccine uptake than others. And then this is projections of where we are in terms of everyone over the age of 12 getting vaccinated. You could see we were exponentially growing, and then we kind of had our inflection point. And that has leveled off. Although, interestingly, the last model I saw of this that was just released yesterday actually has this just starting to tick up a little bit. And the vaccine rates are just starting to tick up. And I think that's largely because of the Delta variant. It's starting to scare a lot of people. Ideally, don't want to have to scare people to get a vaccine, but vaccine is the absolute best protective measure we have, because some of it is not foolproof, but it allows you to make mistakes and still be safe, right? So if you're doing masks and social distancing, if you do masks and social distancing like 90% of the time, but then you go somewhere else where you kind of let things slip and there's COVID there, you can get it. Whereas if you're vaccinated, it gives a little bit more leeway for it. So you can see here, and actually the updated map, The updated map actually is now, this is all in red. It's starting to sweep down in Texas and Louisiana, and then in this like little belt out towards Jacksonville, Florida. And notice that somewhat matches up with our lower vaccine map. And what we think has happened, we've been hearing really bad things coming out of Springfield, Missouri, Southwest Missouri in the last month, because that's where it looks like this latest batch really started, and just their ICUs are to the brink, and they were worried about running out of ventilators. And I would expect in highly populated areas with low vaccination rates, you're gonna see very similar things to what happened in Southwest Missouri last month. So I'd encourage you all, preaching to the choir, but vaccines are super important, and I think we're just seeing an explosive outbreak in unvaccinated areas. So closing thought. Those who can't remember the past are condemned to repeat it. I feel like this has been a very earth-shattering, earth-shaking event, and I really, really hope we learn things from this. So, because this isn't the last time this is going to happen. This has happened in the history of human history repeatedly. So, now what can we learn from this? Or hopefully learn from this? So one, we need to do a better job at respecting nature, wildlife, and domestic animals. Zoonoses are infections that jump from animals to humans, and there are a lot of examples. Ebola, HIV, rabies, COVID. There are other emerging viruses that maybe you haven't heard of, but if they got into the United States, they'd be a little scary, like Nipah and Hendra, viruses that are in bats in Southeast Asia. Our influenza kind of. And agriculture and animal workers are particularly high at risk. So we need to do a much better job at respecting nature, particularly the areas where we're interacting with kind of wild areas, that we need to do a much better job with our agricultural workers and our animal workers around the world, and really have a One Health approach to things that happen in the environment and to animals, if we don't handle them right, can spill into us and cause a problem. Number two, it turns out that people, very smart people in the centuries before us, have figured out how to control outbreaks. They might not have known, they didn't have electron micrographs, they didn't know about virus theory, but they realized that certain people did better than others. And it turns out, so these are all pictures from the early 1900s in the United States, and you can see, you've got keep your bedroom windows open for ventilation to prevent influenza, pneumonia, and tuberculosis. You can see these people are wearing masks in the early 1900s saying, and interestingly, that sign says, wear a mask or go to jail. And this is a classroom in New York City that they decided to hold because there was a TB outbreak, hold it outside in the winter just to improve the ventilation. So what they learned is if you isolate the sick people for a period of time, you quarantine the exposed. So quarantine is an old Italian word for 40 days because they realized that, in 1300s, 1400s, that if they kept ships off port for 40 days, they could let any bad air die out, or essentially get rid of bad air if they waited out 40 days before they allowed anyone onto their land. And that's where quarantine comes from. And the big thing is it's not the sick people, it's people that have been exposed to the sick people need to be quarantined. They realized increasing physical distance worked, minimizing interactions, covering their nose and mouth, maximizing their ventilation, wash hands in high-touch surfaces, and vaccination works, right? Polio, like before the 1950s, like every summer, all the towns across the United States were like terrified that they'd have an outbreak in their pools of polio. We don't need to worry about that anymore because of vaccination. Number three, we need to do a better job at supporting public health at all levels. Public health isn't particularly sexy when things are going well, right? But that's when you need it. You need a robust public health system that can rapidly respond to a situation that's escalating. And the former CDC director basically said his biggest regret is that our nation failed to, over decades, to effectively invest in public health. And that's not just the CDC. Everyone thinks of, oh, public health is CDC. Turns out that public health authority rests with state and local governments. Constitution, Amendment 10 of the Constitution says, if it's not mentioned in the Constitution, it goes to the states. There's nothing about public health in the Constitution, so it goes to largely the states. So state health departments are really important to fund. Local fund are important to fund. And then internationally, so we all cooperate, are really important. So this is a great picture. This was in March 2020. I think this was nationally sent over. And actually, it's two of my friends. One is from the CDC. The other one's from the state health department running a COVID testing drive-through test. So it's just really important to fund this and support public health at all levels. Number 4, we need to do a really good job at investing in rapid emergency research and development. It's impressive we were able to get the mRNA vaccines out so quickly, and the adenovirus vaccine as well, but the mRNA vaccines were really impressive to come out. And then actually being able to test in a randomized controlled trial what works and what doesn't. You can't just say, oh, we think this drug works. Prove it. And look, we had something that was cheap and you can pull off the shelf, dexamethasone. We're able to rapidly do that, and you really need to coordinate academics, private industry, and government to basically be able to do this very quickly in an emergency. Number 5, we need to, particularly as experts and as doctors in the healthcare field, we need to communicate honestly and transparency, because really a pandemic is a communications emergency as much as a medical crisis. And if you don't provide the information, people will fill in the blanks on their own. So it's really important that we're honest, that we communicate everything and that we're honest. So what do we know? It's okay to say, I don't know this, or we don't know this. This is what we're trying to do to figure out. This is our current best course of action. So the idea at the beginning was like, hey, masks aren't helpful. But yeah, we're getting data saying they actually are. Like, hey, we were wrong that masks weren't initially helpful when we said that. We got more data. It looks like they are probably helpful. Let's do that. And then finally, not only healthcare workers, but frontline workers. This is actually a picture from a sign from around my house in Denver. This pandemic showed how much we failed, like in terms of our logistical supply failed. Like our grocery store workers, we put on the front lines in front of this. Our truck drivers, our delivery drivers. I mean, they're heroes. They had to stay working through all of this, and absolutely, we should absolutely respect that and respect them and appreciate them. So those are the 6 things I hope we learned from this, maybe some more. And I'm happy to take some questions.
If you could hang out for a bit and answer questions,
yeah.
I think I'm going to try to get us moving along, because I have a feeling they'll bring the big hook and try to move us out of the room.
If you want, I guess I'll let you do that. It looks like I have 2 minutes if we had a question or two, but I can.
Okay, one question maybe? Anybody? Yeah.
It seems to me that compared to other countries, the U.S. did much more poorly than a lot of other countries. What are your thoughts about that, and why do you think that may have been? Or maybe I'm wrong, I don't know.
I mean, I think a lot of countries had a lot of different challenges. You look at countries in Europe and other places. I think different countries have different challenges for different reasons. So I'm not sure any country, to my knowledge, like a large country, maybe perhaps like some of the smaller countries that could shut their borders and things a little bit better. But I'm not sure of any large country that did this particularly well. But I think the big thing is that the different challenges that we identified, perhaps some countries are learning better than others on how to avoid this. And I really think at the end of this, I think each country and each state needs to go through and kind of have a post-COVID hot wash to go through what worked well, what didn't, and hopefully we learn from that. But anyway, I think my time's up, but I'll happy to hang out in the the back for stuff, but thank you very much.
All right. Our next speaker, I hope the virtual audience can hear me. Is that possible? Yeah. So our next speaker is Michael Rubin, and Dr. Rubin received his medical degree at Texas Tech in Lubbock, did his internship in Fort Worth at John Peter Smith, and then did a residency at UT Southwest in neurology, followed by a neurocritical care fellowship at my alma mater, WashU, in St. Louis, and he also received a master's degree in bioethics and health policy from Loyola in Chicago. He served as an assistant professor of neurology at WashU for 3 years and then joined the UT Southwestern Medical School in 2013. He is currently the chair of the UT Southwest Ethics Committee and a member of the Medical Center's program in ethics in science and medicines. And he co-directs the Ethics in Clinical Science course at UT Southwest for translational medicine. Amongst his many honors, Dr. Rubin is the 2015 recipient of a Presidential Service Award, as well as the Presidential Citation by the Neurocritical Care Society. So he is a big deal, and we're very lucky to have him talking today, as he often talks about ethical issues, and today he'll talk about ethics in brain death determination. So this will serve as a 1-hour CME credit for the Texas Medical Board for Ethics. Thank you.
Thank you very much for that kind introduction, and thanks to the TNS for the invitation, and thank you all for staying. I know you're partly here because you have to get that ethics credit, but you can get it elsewhere. And it's the last talk, and I know I'm fighting against your appetite, so again, thank you very much for staying. But I'm going to give you some great return on your investment, okay? This brain death talk is going to be different than anything you've ever had before. It's got science, it's got philosophy, there's some recent developments that I'll talk about that you might not have come across, so hopefully you find something in it that you enjoy. I have no relevant financial disclosures to this talk. We're going to go over some important definitions. We're going to talk about the foundations of brain death. We're going to explore some unresolved quandaries related to brain death, both from a philosophical and a scientific perspective. We're going to talk about the Uniform Determination of Death Act and where it may be going in the future. And finally, I'll wrap up with, well, what I think we should be doing as neurologists. So to start with some important definitions, a frequently debated topic is, should we be calling it brain death, or should we be referring to it as death by neurologic criteria? Those that want the second term are saying death is death, and we're simply just looking at it from a different perspective. And by even calling it brain death, people won't understand that it's equivalent to a cardiopulmonary definition. And people can go on and on for hours going back and forth. So the folks that I've published with on this topic, we have resolved to simply say we're going to call it BD, DNC, and you can choose whichever term fits you better. Epistemology, this is a philosophical discipline where we look at how we learn things, how we acquire knowledge. So there are volumes written about this. This was a very important topic in ancient philosophy. And it's part of how you live your life and how you learn and evaluate without even realizing it. But we use both of these techniques. We use a rational approach to knowledge. We also use empirical approaches. There are those that think you really have to choose one or the other, but I would argue that on a daily basis, you're really using both. So the rational approach is based more on intuition, on taking your previous experiences and going with your gut when it comes to philosophical questions, when it comes to values. That's really the process that you're using. With empiricism, of course, this is the scientific method. It's using observation, using your senses, going with the data, even if it leads you to a place that you didn't expect. And so if you think you don't use rationalism, think of the last time you read a study and it was well designed and the data was good, but you're saying, no, I'm not buying it. Right? I mean, that happens all the time, that we say this is just not close enough to my own experience that I just can't commit to it. Another good example, if you're driving down the road and you pass someone on your right and there's no other inlets to traffic, you could decide when you want to get in the right-hand lane, are you just going to get in that lane, or are you going to look over at your blind spot? So the empiricist would say, yeah, I know there's no one there because I passed that last guy, but I'm still going to check. So on a daily basis, you're really using both, okay? However, it's important to know which tool to use in which circumstance, because you can't use science to answer a philosophical question, and you can't just rationalize the way through something that you can explore with observation. So let's start with the foundations of brain death, where this came from. On a very conceptual way, before modern technology, if your heart and lungs were to stop, you would stop perfusing your tissue. It would die. You would not be able to maintain homeostasis, and then you'd have something we call death. Likewise, if you had a catastrophic brain injury, you may go into neurogenic shock. You may lose your ability to drive your ventilation when your brainstem's not working. Your heart and lungs would stop. You would not perfuse your tissue. You would lose homeostasis, and we'd call that death. Now, before we had any tools to interrupt these processes, they all just kind of happened the same way, and it had the same result. So there really wasn't much debate over what death was. There was some concern in the Middle Ages about, is someone really dead? And they had these bells that you could like ring, that they were attached to your grave to make sure that if you woke up, you could let people know you need to get out. But generally speaking, we all kind of agreed what death looked like. With contemporary technology, everything is up in the air. Okay, if you have a cardiopulmonary arrest, we can often bring your heart back. We can put you on a ventilator. We can put you on ECMO. Often there still comes a point that these technologies have failed, and then loss of homeostasis, death. With catastrophic brain injury, we have an even harder situation where a massive injury can lead to cardiopulmonary insufficiency or failure. But your brain may progress to the point that it has absolutely no function. So what is that? That's the part that we're trying to figure out. That's the part that is often called brain death. So here's a brief timeline that really shows how these concepts developed concurrently. As we were progressing in our understanding of what it is to have cerebral edema and brain compression and loss of function in a serial fashion, we were also developing the technology to restore your heart function, to artificially ventilate you. And then we put this stuff together in an intensive care unit, and it became quite clear that the boundaries of what we call death were getting obscured to some sense. And in 1957, the Catholic Church recognized this and said, you know what? This is all going to get very complicated. We see it happening. So we're going to say the physician is the one that's going to say when the moment of death has happened. And at that point, there's no need to continue life-sustaining therapies, organ support. Our understanding of coma continued to develop. Probably the book that everyone knows the most about is Plum and Posner in 1966, where we learn more about stupor and coma and how there's different levels and how one leads to the other. At the same time, Molière and Guyon, which had a very profound influence on the field, said we have these series of patients and their injury is so severe that it's hard to just call this coma. Our coma patients usually have some chance of recovery. These patients aren't coming back. This is a irretrievable coma. So it's like a coma plus plus. They didn't call it brain death, but they said this is something else, and we have to figure out what it is. At the same time, Beecher was starting to talk about these ethical problems that we're coming against. We've developed this great technology. We're helping keep people perfused and their lungs and hearts working. Some of them did wake up and recover, but a lot of people weren't. And we had to lean into it and see how we were going to deal with it. So we need to talk about death. We need to talk about what it is. There's one thing that everyone agrees on, and that is death is an irreversible transition. When the moment of death has occurred, if it's still a moment, after that, you're not coming back. If someone does come back after we said they were dead, they really weren't dead, we got it wrong. Okay? So this is the one thing that no one's going to contest, that death by definition is an irreversible transition. And we saw this in the ancient world. This is Charon crossing the river Styx. After you died, you give the boatman a coin and he would take you to the afterlife. So we've always known, even in the infancy of man's exploration into knowledge and philosophy and science, that there's something definitive about this moment of death. Which is why if one were to return after being diagnosed as death, it's seen as a divine act, because only the hand of God could bring you back from a truly transition through death. On a conceptual way, if you want to talk about death, you also have to say, well, death is the loss of life. So maybe what we're really talking about isn't what is death, but what is life, and then death is loss of life. So there are components of it that are very particularly organic, biochemical. Life involves complex molecules that are arranged in a very particular fashion. A living organism can maintain homeostasis. It can respond to the environment. It usually replicates, reproduces, perpetuating its organization through time. But there's also a question about life as something else, as maybe an emergent property. If you took a mammal and took all of its organ systems and put them in jars and did a good enough job of supporting them, are each of those organs alive? They can maintain homeostasis. They can respond to the environment. If you give them the right nutrients, they could stay that way for a long time. So that decomposed mammal, did some element of what is living get lost as it's been deconstructed into its parts? So is there a cellular life? Is there a tissue life? Is there life as an emergent property of an organism as a whole? And then how does death apply to that? When you lose both the organic component, you start to inevitably lead into definitions that feel less biologic and feel more philosophical. So maybe death is the end of all vital processes. So some components can still be working, but overall, as an organism, you're not functioning. Maybe life and death is all about the organism in its entirety and not its subcomponents. So are these biologic questions or are these philosophical arguments? When you apply that to brain death, often the arguments for it being equivalent to cardiopulmonary death are divided into a biologic sense as well as what is a human organism. Certainly the ability to maintain homeostasis is an essential part of being a living person. I think one could also make the argument, are you truly maintaining homeostasis if we're giving you all your nutrients and your oxygen and clearing your CO2? Are you really responding to the environment, or are we doing it partially for you? If you want to look at brain death through the whole brain death criteria, which is largely what the Academy's position has been, you have to look at the complete loss of the brain. It's at least, if it's not death, it's dying interrupted. Without these technologies, eventually your heart and lungs would stop. If your brain's not functioning, are you really breathing? The ventilator's working, but you've lost your drive. So is that a breathing organism or is it something else? Those that want to delve into the philosophical side we'll talk to you about the higher brain death concept. So is it our capacity for consciousness to understand ourselves and the world around us? Is that which makes us uniquely a human organism, in that if that itself were gone, then we're no longer a living human being? Hard questions. And I think as much as we talk about the infancy of this field as being clear and definitive and there not being questions, they sure were not completely certain either. So if you look at the original Harvard criteria for irreversible coma, the headline is a definition of irreversible coma. It's not, we're going to tell you what brain death is, right? They were sure this is irreversible coma. And then the subheadline is say, ad hoc committee, yada, yada, Harvard, definition of brain death. So we're kind of pushing that concept into the literature, but there's still some uncertainty if that's really what we're talking about. What really solidified brain death as a social policy, however, was the Uniform Determination of Death Act. So this was subsequent to a president's commission that tried to answer the question, is someone without any brain function alive or dead? Is it equivalent? Their answer was yes. The American Medical Association said yes, that's a thing. The American Bar Association says yes, brain death is equivalent. The Uniform Law Commission, which is kind of an organization that tries to keep consistency in state laws that are necessary from one state to the next so they're not too confusing, said, yes, we're going to create a law and we're going to define death by these two ways. I think the most important thing from this slide and from this concept is this just wasn't us. Okay, this wasn't, the UDDA was not just physicians saying brain death is death, we're the doctors, we get to decide. There were lawyers, there were legislatures. This is a matter of public policy. So brain death was defined as equivalent, not just because of the wisdom of neurologists or physicians, but because as a greater whole, society got together and said, this is what we're going to call it. And by their definition, death was defined by either loss of respiratory or circulatory function, or irreversible, again, there's that word irreversible, which is key, cessation of all functions of the entire brain, including the brainstem. The fact that it was labeled all functions of the entire brain led to many questions later, but that's where it was left. And the UDDA also said that the criteria to be used are the medical standard of the day. So in 1995, and think about it, you know, this has been like 40, 50 years in the making that it took for the Academy of Neurology to come up with the standard that we apply today. So it took quite a while to develop this policy and to have very clear criteria to guide its members. So of course you need to have a cause of your unresponsiveness. You have to rule out these important confounding factors that may obscure neurologic function. Hypothermia is by far the biggest concern, as it can really mask your metabolism. You have to be warm, you have to be perfusing, and then all of the neurologic function that we can test at the bedside we do. And finally, you finish with an apnea test. Ancillary testing can be used in select circumstances, but was not recommended to be your primary means of determining brain death, hence the word ancillary. So what was left unresolved? So first we're going to talk about the things that we can use science to explore. Has anyone that we've said is brain dead by this criteria ever come back? If we all agree that death is irreversible, have there been cases where we got it wrong and they've returned? Are ancillary tests as good? Are we all doing this the same way? Are the practices in each individual hospital and the policies that are guiding you, are they consistent with the national guidelines? What about the troublesome issue of neuroendocrine function? So you may meet the accepted criteria for brain death, but not be in DI, Often people all go on to develop DI, but if you still have some hypothalamic or pituitary function, is that part of all functions of the brain that must be lost? So what are we going to do about that little part? I guess the other question is, if that's the only thing that's left, do those people come back? What about integrative function? So one of the essential cores to why brain death is a biological determination of death is that without all those inputs and guidance, all the things that the brain has with the rest of your body, if those are gone, the rest of your systems will fail. So that we could probably test empirically. We could see if what happens in time where all the systems inevitably fail. It's a hard thing to study, though, because if we all agree that brain death is death and we're discontinuing organ support after the diagnosis, it becomes a self-fulfilling prophecy, right? Like no one's going to launch a randomized controlled trial of anyone who's been diagnosed. Some people we discontinue, some people we keep supported, and let's do that on 5,000 patients. We're not going to do that. However, in some sense, we kind of are running a case series now because there are states that allow religious exemption to brain death criteria. So I imagine at some point, someone's going to collect all those cases and show what happens, and we'll see if that's a good thing or a bad thing. What we can also study with science, and this is with the social sciences, is do people believe this? When we sit down and tell people what brain death is, do they accept it conceptually the way that we're trying to communicate it? Do physicians and nurses believe it? Or are we doing this and saying, wink, wink, it's not really death, but it's close enough? What about our chaplain partners? What about the public? That's something we can study. It's tricky because it's very personal to ask people these questions. It would be hard to ask people that are going through this process because they're undergoing such grief. But that's something we could probably use science to learn more about. So as far as are we all doing this the same way? This has been looked at in great detail, and the answer is no. In 2010, the same group that created the original guidelines said we're going to give an update, and we're going to look at all the cases of reported recovery of function after brain death determination and say whether they really recovered or not. Was there really a reversal of death? Their report was with all the information that they had, given that it's going to be limited. Anyone who was said to have recovered after a declaration was not appropriately declared, which, you could say, well, are we moving the goalposts? Are you answering the question by just emphasizing your conclusion? But at least as best they could objectively say, there has not been recovery of neurologic function after an accurately performed brain death testing event. They did admit that we don't know how much time we would have to wait in order to show that such a determination was irreversible, right? Which, there's no way around that. If you say it's irreversible, is a month enough? Is a year enough? We're never going to do that study, at least not in an intentional manner. So what about variability of hospital policies? So in this first study by Greer, he looked at over 508 hospitals, got good enough data for 492, and found that we fell short. It's usually in the high 90s, but there's often an element missing here or there that wasn't documented as a necessary element in your policy. Now, that doesn't mean people aren't doing it. It just means that the policy didn't tell them to do it. This follow-up study looked at just the top 50 U.S. News and World Hospitals. They wanted to see the impact of the 2010 guidelines, which re-emphasized we have to be doing this well, we have to be staying close to the accepted guidelines, and found that hospitals were, on average 92, 95, they got up to 97. So still there was room for improvement, but not all policies are still consistent. this graph is a little hard to interpret. I almost should have drawn a line at 68. So this is the amount of people that have performed brain death determinations at 3 different centers. They had 68 respondents, and this is what they're saying they're actually doing. But you can see there are between 12 and 1 or 2 people amongst the group that said that they're not doing all these elements when they do brain death testing. So we're probably not staying completely compliant with the suggested guidance. Integrative function. Is this something we can explore empirically? Alan Schumann, who was originally a supporter of brain death and is now one of the most vocal opponents, argued in this paper on his analysis that there are situations that we can continue to support what he would call people. Those that are proponents of brain death wouldn't call them people anymore. But he said, yes, they're people, and we can keep their bodies sustained for months, even years, if we get good at it. So he's saying that the integrative function is a fallacy. It's not really a thing, because it's just a limitation of the technology that we have, that you can have a organism that's sustained, homeostasis can be maintained, if you're good enough at it. However, this is still very controversial, and again, one of the hardest things to ever prove one way or the other. He is willing to admit, though, that of those cases he followed, eventually they all did have a cardiopulmonary arrest at some point. So if it's not an essential, necessary component of integrative function, it certainly is a lot harder to continue to sustain your other organs without a functioning brain. So what about the social science? Do people believe this? Is this a thing? This was a decently done study. The highest consensus was on the concept of brain death being brain death because I'm applying the Academy criteria, the whole brain death criteria. 88% of the respondents, these are all neurologists that are practicing, said yes, if people meet the criteria, they are not alive because the whole brain death is the standard that we apply. Often people will say, well, that's what the law says. That's what the Academy says. And they take that as the basis of their belief in the validity without really leaning into what is their true underlying understanding of it. Almost half the respondents also endorsed the higher brain concept. So that brain death is death because your ability to have consciousness or the potential to recover your consciousness is an essential part of being alive. So there are philosophical underpinnings within our community for sure. What about chaplains? Okay, they think a lot, they pontificate, they pray, they think about death all the time. So if anyone's an expert on what is death, you would think it would be a chaplain. So let's ask them. We'll focus on those that have been in cases of brain death, specifically where families have disagreed with the diagnosis, where they have resisted your conclusion. 84% of them believed that if you meet the AN criteria, you're dead. And so you can say, well, 84 is pretty high. Well, it is, but that also means that 16% of them are not buying it completely. That brain death is something different than cardiopulmonary death. And 30% of them said that if a family wants to continue organ support, that's their choice. So if you truly think someone's not alive, then you wouldn't necessarily give people the option to continue organ support at that point. So there's a lot of doubt that we don't like to talk about over really is brain death a cardiopulmonary equivalent. So what can we look at rationally? What should we use philosophy as a tool to try to understand better? I guess the big one is it the same thing? Is it morally equivalent? Do we think it should be legally equivalent? Is it something close that's close enough that we should continue to support it. We just use a little bit different nomenclature. Is it all really about consciousness? Is a human life different than the life of a paramecium, such that we define life differently depending on the complexity of the organism, or is it really all about biology? There is a significant vein of argument that brain death was never really believed to be death, that it was a means to an end. They bring up the dead donor rule, which is actually not a rule. There's not like a plaque somewhere that says the dead donor rule, but it's an accepted standard that organ recovery should not be the proximate mean of someone dying. And the thought was, well, brain death was created so you could take a person whose organs were perfused and say that they're no longer alive, so we can respect the dead donor rule. This concept probably caused the most consternation and anger, but it is something that I think should be considered and is something that is often talked about. What if you have a religious objection to brain death? So what if you're from a faith tradition that established its concept of death long before our modern technology, and they offer no guidance for brain death, and so your clergy have concluded that brain death is not death? What if they say, I can't discontinue things, it's not consistent with my established worldview? Should we allow those religious exemptions? Or are we going to say if it's death, it's not an option, it is what it is, and we can't continue that artificial support? Consent for apnea testing is a more recent question. Really, this kind of came into the conversation because if you had an objection to brain death testing being done, you could say, I will not let you do an apnea test because an apnea test involves risk. So I should be able to consent or not consent to it, therefore you can't follow the criteria, therefore you can't diagnose brain death. So there's an argument whether this is something that we should give people an option to opt out of or not. Is it an essential diagnostic that people don't have a choice about? And I guess if we push too hard on this issue, people would just probably do a lot more ancillary testing. This is a great review article by Jim Burnett, who, if you've ever studied or thought about brain death, I'm sure you've read an article by him. And really, I put this up here to show how acknowledgement of these unresolved questions is not something purely in the vein of the philosophical literature, that there are neurologists amongst us that are considering these things, that think we should lean into it, that we should explore it, because if we don't, we won't know how to respond when these doubts come up, or when our patients ask about it, or when the public sentiment veers away from our belief in it. And I think one of the things I love about his writing is he explores these issues and gives them a chance for their argument to enter your mind without completely dismissing them. So he's a great almost navigator through this realm. Bob Truog is one of the most well-known opponents of brain death as a equivalent criteria. His work, along with one of his colleagues, Miller, have led to what people frequently call the Miller-Truog hypothesis, or the Truog-Miller hypothesis, which essentially says that, again, this all came out because of the dead donor rule and the need to recover organs, and that brain death is essentially a legal fiction. So just as someone with really poor vision may still be able to see some things, we've established that there's a cutoff, that once your vision is beyond that, we're going to legally call you blind, because there has to be some line. And he's saying, essentially, that's what we did to respect the dead donor rule. We came up with something that's as good as close enough, and we called it brain death, but it's not really death. So what we should do is just get rid of the dead donor rule and let people willingly give their organs, even if it's going to be the cause of their demise, which that's a whole nother conversation. That is a huge debate, whether that's a good idea as a public policy, whether that has moral grounds or not, is hotly debated. But usually people like me that talk about brain death don't get too much into the dead donor rule. We try to stay away from organ transplantation. I'm part of the group that's currently rewriting the guidelines for brain death. We're trying to come up with one guideline for them all, so to speak, that includes pediatric criteria and adult criteria. And all of us very clearly had to indicate that we don't have any relationships with organ procurement organizations, because we don't want to give the message that somehow we are advancing this cause because we have some ulterior motivation. So we're all, clear of those associations, which in some sense is a shame because, they want to hear what we have to say about brain death, but we have to make sure that we at least don't have any financial arrangements with them. And that's pretty important for public perception. Trug emphasizes more than anything that that biologic death is all about homeostasis. That's the core of it. That is the most fundamental biological definition of what it is to be a living thing, in that we should restrict our understanding of life and death to that one component. In this particular article, he also talks about Robert Veitch, who's a really well-known philosopher as well, and he takes a little bit of a different stance that says we should keep the dead donor rule, but we should have expanded criteria for ill enough to be potential sources for organ recovery. And they're pushing hard on this. Okay, this is not just a one-off paper. This is not something that is hidden at the bottom of a shelf. They're reporting a lot of it, and a lot of people are giving it attention, and it's gaining traction. This recent paper that they put out, I think just a couple months ago, they talked about a German woman who met criteria for brain death. She was pregnant when she was diagnosed, and they continued to support her all the way to term, and she delivered. So their argument, given it is one experience, but you could always counter, well, you're only going to have one experience here or there because we don't continue to support, that if the death of an organism is the overall functioning of the organism, this woman still very much was functioning. She was able to carry a fetus to term. So there might be something to that. And we need to just accept the fact that it's not biologic death. It's something else. It's a judgment. And it's time to recalculate how we're approaching these issues. So legal challenges. Often these questions come to us through public attention if you're not reading the philosophy journals. And so some of these will feel very familiar. Jahai McMath, I'm sure everyone's heard about. And I think at the core of all these, you see they're often young people. There's some tragic event, and there has to be at least part of these case law that has to recognize that a lot of this is about grief and suffering and people having trouble accepting the horrible realities in which they were part of. So Jahai was 14 when she had a horrible surgical complication. She was diagnosed to be brain dead. Multiple opinions of diagnosis were repeated. It went up through the courts. Jahai was transferred to New Jersey, which allows a religious exemption. And her family's claim was not that she wasn't appropriately diagnosed, but that she had regained neurologic function, so that the criteria themselves are not valid. They had videos. She had this a Facebook page where people could testify their belief, and they showed videos of her, and they have pictures of her kind of twitching her thumb a little bit. Whether that was a spinal reflex, we don't know. It was a very limited viewpoint. They show a picture of a ventilator, and it's set to 13, and she's breathing 14 once in a while. So is she overbreathing the vent? Again, these are, selected videos. There was discussion about having her independently examined by some of the leaders in brain death. However, she had a cardiopulmonary arrest before that occurred. However, I think some of her cases are still pending. Aiden Haley, this was a case in Nevada where another tragic event, a woman was diagnosed with brain death, the family resisted. Eventually, it got to the Supreme Court in Nevada, and they said, you know what, she's not brain dead, because no one ever said that the Academy of Neurology was the standard that we all have to be following. And we believe it's the Harvard criteria, because they came out first. You didn't do an EEG, therefore she has not been diagnosed as being brain dead. However, like many of these cases end, she went on to have a cardiopulmonary arrest, and so the case became moot at that point. Israel Stinson's also a very well-known case. Again, another tragedy. Patient was diagnosed, transferred out of the country. When they returned, it was determined that that determination was still valid, and organ support was discontinued over the family's preference. 3 more cases. Colleen Burns was declared regained consciousness on the way to organ recovery. Oops. So not regained a cranial nerve, didn't start having a pupil, regained consciousness. So something was clearly done inappropriately during the declaration. Who knows? Maybe a confounder was not considered. In the case of Isaac Lopez, a 2-month-old that was subjected to abuse, family disagreed with the diagnosis. There were allegations that part of their motivation was to reduce the legal risk to them because they were the abusers. And eventually the court didn't allow those arguments to persist, and the patient's organ support was discontinued. Not too long ago, the Munoz case happened in Fort Worth. A woman who was pregnant was diagnosed as being brain dead. The family, the husband, wanted to discontinue organ support. He didn't think she'd want to be in this case. However, the hospital said that we can't do that because there is a law in Texas that says if you're pregnant and you're still alive, that support can't be discontinued if you have a viable pregnancy. However, eventually the court did recognize that that law did not correctly apply because she was declared to be dead, and so support was eventually discontinued. But that one was a little bit different because usually it's the family arguing to continue support, and here there is a case where the hospital was arguing for the necessity of continuing support. So a lot of folks say, what we need to do, if this all started with the Uniform Determination of Death Act, let's just rewrite the thing, right? Let's take the things that are unresolved and just put them in the law. Let's take out the hypothalamic stuff. Let's say the Academy criteria are the criteria, and then we won't have to debate it because the law will be the law, and then we'll move forward. And so some colleagues of mine are working on just that. So they took the first 2 elements of the UDDA, they're calling this the Revised Uniform Determination of Death Act, and they're adding that the functions that we're concerned about are an unresponsive coma with loss of capacity for consciousness, brainstem areflexia, and the ability to spontaneously breathe. So they're saying, let's not leave it open what all functions of the entire brain are. Let's tell you the ones that you have to prove aren't working. So higher cortical function, which many people endorse as the core of what is to be brain dead. Lack of brainstem function, inability to breathe with the apnea test. And they specifically say that you should follow the Academy criteria or the SSEM's criteria, or in the case of pediatric cases, the AAP CNS guidelines, and then they threw in subsequent revisions, because if the criteria that sums all of them up are going to come together, we're eventually going to want those to be the criteria that people are using. And while there should be efforts to reach out to a family and tell them that you're doing the diagnosis, that consent for apnea is not needed. So we'll do that, and then these conundrums will be resolved. However, of course, the people that don't believe in the concept of brain death retorted in the literature and said that, no, we're not buying it. That the guidelines that you're proposing we use, there have been cases of reversal, so they're not good enough. Hypothalamic function can't just be excluded because, as we saw in the case of the a German woman whose pregnancy was carried to term, if anything is more important to the function of the organism, it's your hypothalamic function, which directly impacts how other organ systems work. They think apnea testing does involve risk, right? Even if you do the best job of pre-oxygenating and using pressors to prevent shock, there is a chance that you could have an arrest doing it, so therefore you have to have consent. And most of all, they said, you can't just say, we believe all this stuff. This isn't just up to physicians. There is controversy here. Not everyone believes it. Therefore, you have to give people an ability to opt out of testing or the diagnosis. So let's see how this is going to play out. And this was just a handful of days ago. This is from a gentleman named Thaddeus Pope, who's a very active legal scholar in futility and brain death. He has this great blog called medicalfutilityblogspot.com, and it goes over every new case about futility and brain death in Europe and the United States. Really interesting. And so I noticed this just a handful of days ago, that the Uniform Law Commission has considered revising the UDDA and unanimously agreed that we should revise it. So is that good? I mean, who's going to be on the committee? It turns out that not everyone on the committee is a member of the Academy of Neurology. People that disagree with the diagnosis and the veracity of brain death as death are also going to be a voice on this committee. Okay, so this could backfire. What if apnea does all of a sudden start requiring consent? What if the hypothalamic definition does get inserted? What if a patient has to be in DI for you able to diagnose them? Those are all potentials. The good news is when I poke around and ask how long does it take from a commission to be formed for the laws to be written and all the states to adopt it, they're like, it's about 10 years. I'm like, okay, good. So, we got some time. We can still get into this and argue one way or the other. This change is not going to happen this year. So what should we do as neurologists? What are you going to do with all this material? This is a case that happened in Tomball Regional Medical Center. Everything I'm telling you is per the article from the Washington Post. So I have no means of verifying their reporting or offering more insight to what the article said, but I assume that they had adequate clearance and consent and HIPAA was respected. But essentially, a gentleman was in this particular medical center. He was a known epileptic, and per the article, the family was told the patient was brain dead. Whether they were really told that or not, I don't know, but that's what they're reporting. Father was at the bedside and was pretty sure the son was squeezing his hand, and then it wasn't reflexive, and then the son wasn't dead, and they were going to turn off life-sustaining therapy, and Dad pulled out a 9mm handgun and threatened the staff. And a SWAT team was called in. Fortunately, it ended peacefully, but the patient's now awake. He wasn't brain dead. Dad was right. So what criteria did they use? Was it a neurologist or an intensivist who has training? But these cases are out there. So more so than anything, if there's one thing that we do right is make a good diagnosis. If you're not sure, don't diagnose them as being brain dead. It really only takes one or two cases to blow up the media and the literature, and not to mention it probably means a lot to that person and their family. So if you have a posterior fossa hemorrhage and there may still be cortical function, but you're not getting any cranial function, that person might not be brain dead. So repeat the scans. If you still have barbiturates that haven't cleared, wait a bit longer. Wait until they've cleared. Don't just rush around it and get an ancillary test and then find on the way to organ recovery that they start having cranial nerve function. It doesn't take many of those to really completely undermine public trust. So here are quotes from when I went online to read the article. These were comments from people that were reacting to it. And obviously, this is on the internet, so it's anonymous, and who are these people, and they don't have to own their arguments. But there is a consistent theme that they think the reason, of course they got it wrong, and doctors do it all the time, and they should be fired, and they're doing it because they're trying to get your organs. And they're getting paid to get your organs. So this is a real concern. This is a very common public perception of why we're doing this testing and why it's so important that we separate our function from those that are recovering organs. Know your policy. Yes, you've been doing it for a long time. Maybe your policy's changed. Checked out your policy. If something goes sideways and you didn't do it how your policy said you should be doing it, you could get yourself into trouble. If your policy is not up to date, help rewrite it. If you don't have a policy, you can go onto the Neurocritical Care website. David Greer, who's done a lot of the work where we say how unreliable a lot of policies are, he has a policy up there for you to use for free, no charge. Download it, smack your name on it, it's yours. Really good, well-written policy. We also have a brain death training course on there that I was part of. I don't financially gain by you using it, but I would say it's a pretty good course. It's got videos. We have a didactic portion. We have real-world examples. There's a test you can take. So some people see it as a potential way of building up some kind of certification that you know how to do brain death testing. If the family is refusing, just suppress that urge to think that they just need to accept the law for what it is, recognize that it's a very delicate moment, that they may still be working through their coping. Even if your policy says you don't have to continue support, consider whether giving them that time would help them cope and understand the situation. In my experiences, family that don't accept a diagnosis, they eventually come around to it. You know, it's a lot to accept. Some person who you just met a day or two comes in and say, I know the heart's beating and the lungs are going up and down, but your loved one is gone. That's a lot of trust. And for some people, that's gonna take a moment or two before they can really come to terms with that. If you find yourself in a corner and you don't know what to do, call for your ethics consultant, talk to your chaplain, get some extra help, and take the time and consider redoing your testing. Doesn't hurt to read the literature. These arguments are coming, they're being spread, more people are referring to them. Someone might come up to you and ask you what you think about it. So even if you are a strong believer in the biological definition and you think the rest of this is nonsensical, you should at least know enough about it so you could respond to their questioning. And that is the epistemology of brain death. Thank you all very much. Any questions I can answer? Right here.
Hi, so I'm a pediatric neurologist, and I have a particular interest in the NICU, the neonatal ICU, not the neurologic ICU for the adult people. Yeah. Has there ever been consideration about putting a gestational age on brain death criteria?
I don't think so. I think, the concern that often comes up is the lack of suture closing, and that even with elevated ICP, you might not have loss of all their function. So there is discussion about creating a so-called cutout for the pediatric population, that there may be a minimum age that is necessary for the diagnosis to be made. But that is not definitive at this point.
And I guess if you use that, would it require the fontanelle having to be closed? Because that can vary from kid to kid.
That's a good question. You know, at what point do you know it's irreversible? At what point do you know it's complete? In adults, when you have a massive increase in ICP, you know no matter what you do, you've lost control of it, your mannitol has failed. If it hasn't happened, it's going to happen. But you don't have that uncertainty with someone with an open fontanelle.
Thank you.
With the hypothermic protocol, which is becoming almost an inevitable thing nowadays, does that influence judgments, waiting for 48 hours, or do you have to go beyond that?
Yeah, that's probably that is the biggest concern with confounders. And if there are people that are making missteps and there is recovery of function, there was actually a published case where a patient regained function and it was subsequent to being on target temperature management. I usually don't reference the paper because their title, I think, was written to be controversial, to get more attention, and it inserted more doubt into the diagnosis. But yes, that's absolutely a concern. I mean, we debate over when you can even prognosticate after target temperature management for someone that does have cranial nerve function. Is it 48? Is it 72 hours? Often these people are on tons of sedation. So we usually recommend at least 48 to 72 hours after warming up before you would attempt a diagnosis. And if they were on long-acting agents, you may need to wait even longer.
So I sit on the brain death committee at our hospital, and one of the few times that I've nearly gotten burned has been with neuromuscular blockade. So I wondered if we should have included a train of
The train of 4, yeah.
Yeah, train of 4, just to make sure that there isn't neuromuscular blockade. But none of the professional organizations have really brought this up. What do you think about that as part of our brain death criteria?
So they do suggest you consider such confounders as paralytics, but they don't say you have to prove it by actually doing a train of 4. In my particular practice, I always almost do it. You know, someone got intubated in the ER, and even though I think there's no reason it cleared, it's one thing that I can show you is not a factor, and so it's worth the 2 minutes it takes to do it. So I don't think it's unreasonable that you create a policy that goes beyond what the guidelines, national guidelines say. You can always say, and the way that we are going to demonstrate that is by doing this.
And I think that's what we've tended to do in the pediatric hospitals.
Yeah.
We've always exceeded the time periods that are generally recommended for consistent examination, an exam consistent with brain death. But these are things that it could go on ad infinitum. I mean, you just can really continue to check and double check yourself.
We say 24, we say 48. You know, we use these numbers because they seem about right, but there's no way to know. And one of the things that is currently under consideration is in the pediatric world, you're doing 2 exams. In the adult world, we're doing 1 exam. So if we were to make one guideline, is someone going to give? The argument against the 2 exams is if you're doing it right the first time at the right time, long enough that confounders have been ruled out, then that 1 exam should be adequate. Often folks from the pediatric world will emphasize that those 2 exams are very important to help give the family acceptance of the diagnosis, that you're showing more than one person has looked at this and agrees with each other. So there may be value beyond the scientific proving of the diagnosis in avoiding the trauma of the situation or helping people cope that is worthwhile to consider.
Any other questions? Thank you for a very thoughtful, well done talk.
Thanks.
And that concludes the summer meeting of the Texas Neurological Society, the first hybrid meeting of a Texas professional society that I know of. Thank you.